Hello everyone. So now we will start afternoon session. So it is time to start Young Researcher Invited Lecture 1. The chairperson is Dr. Masahiro Yamada from Tohoku University. Thank you for your time.
Hello, everyone. Thank you for joining this international symposium. This symposium delivers a wide range of the cutting-edge research from the three invited youngsters. Please feel free to enter your question in the Q&A box anytime. Okay, I will introduce the first speaker, Dr. Kitapong Rosang from Chiang University in Thailand. His title is Coriander vs. Candida, a new regimen for the oral candidiasis treatment. Please start your presentation, Dr. Rosang.
Thank you for your introduction. Okay, let me share my screen first.
Please.
Okay, can you see the screen?
Yes, I see.
Okay, thank you. Okay, today I would like to talk about the project that we are currently running at our faculty. So it's like share the idea of the project that we are working right now. So the project is about the coriander versus the candida, a new regimen for oral candidiasis treatment. This is our faculty, the Chiang Mai University, Faculty of Dentistry. So we have a very big and old tree here, and the weather is very nice. Okay, let's start with our target first, the candidiasis. The candidiasis is the infectious disease. It's caused by the overgrowth of the candida subspecies, for example, the candida albicans, the candida tropicalis, but mainly it's caused by the candida albicans. So the oral candidiasis can be divided into 6 classifications, depending on the causes and the clinical characteristics. But all of their classification share the common trait is that it causes inflammation in our oral cavity, and more important that it is a risk factor for the malignancy, especially in the patient with oral PMD. The common symptoms for the candidiasis is pain or the burning sensation and the discomfort, oral discomfort. Their clinical feature is like there can be erythematous lesion, pseudomembrane, or the white plaque. The pseudomembrane can be wiped off, but the white plaque cannot be wiped off. Normally, the treatment right now that commonly used in worldwide is the antifungal drugs like nystatin, ether with the vaginal tablet, the suspension or lozenge, the cotrimazole or the miconazole gel to apply on the affected area. And also the antiseptic agents like sodium hypochlorite or the chlorhexidine. And yeah, it has been approved that all of these agents or all of this drug is effective in killing the candida. But the point is that they only have so effective, I mean, only one effect, that is kill the fungal. But what about the other aspect, like the inflammation or the risk of the cancer? All of this medicine or of this agent cannot suppress the inflammation directly, or cannot reduce the chance of the candidiasis. So we need to find the alternative treatment for treating the oral candidiasis. So it's come to the herbal medicine. The herbal medicine is now currently world trend because after we developed the modern medicine for quite a very long period, people start to thinking of what about we using something that we already have, not producing something new. So they try to dig out the old knowledge, like from the Ayurveda or the traditional Chinese medicine or traditional herbal medicine. They dig it out and rethink about it and try to apply them to our to treat the new disease that we're having right now. So this is our main character here. is the coriander. The coriander, or you can say that in the Thai name is pakchi. Their scientific name is Coriandrum sativum. The coriander we are going to talk in this project is the coriander seed oil extract. So we take the seeds from the coriander and we extract the oil from the seed. The coriander seed oil extract already approved that they have the antimicrobial for the fungi or for the bacteria, and also the anti-inflammatory effects and also antioxidants. So this is the major component that have the effect to inhibit the bacteria or fungi, have the ability to reduce the inflammation and the ability to antioxidants. I would like to talk a little about the linalool because the linalool is most one of the most common found component that we found when we extract the coriander seed oil extract. Linalool is a terpene alcohol group. Actually, linalool can be found in several flowers and the spice plant. The plant has a spice taste. It has a benefit like antimicrobial, of course, the anti-inflammatory, antioxidant. It also has the sedative effects on the CNS and the mild convulsant effects too. And actually, it has been approved that it has the ability to inhibit acetylcholinesterase, that it can be used in the Alzheimer's patient to increase acetylcholine and improve the cognitive of the patients. For the antifungal effects of the linalool, it can disrupt the membrane integrity and cause the leakage of intracellular matrix and arrest the cell cycle. And DS et al. At 2018 have already proved the effects of the linalool against the Candida species. Also, the anti-inflammatory effect is already has been proved also in vivo case by inject them into the subcutaneous injection, and they prove that they can reduce the system the inflammation in the systemic way. The antioxidant also have the has been approved too. They already have the clinical trial in the patient with the carpal tunnel syndrome. They inhale 1% of linalool and it increased radical scavenging activity in the plasma. That means it can reduce the oxidant. So this is the list of all active components that I took time to review all of them, whether it has the antifungal, anti-inflammation, and antioxidant or not. I can find that most of them have all of these three effects, except something, some of them that still have a quite questionable effect that is not is borderline effect that is not has been completely proved yet. So the question is that this active component work better in combination. I mean, more than separately, or it has a synergistic effect or not. So the aims of this project that to develop the antifungal and anti-inflammatory product for the clinical use. The laboratory method for this project is to use the fractionation method to separate the fraction from the coriander seed oil extract and use the HPLC to identify the component. Right now, we're running the pilot study for this project, for this part. Since this is the currently working project, so I cannot tell you the exact result right now. But at least I could say that each fraction have the ability to kill the bacteria, kill the fungal, kill the candida. But what we aim right now is that we want to find the proper concentration and pair up each component and all the fraction to determine which fraction matching better or which component matching better that is have most effect for the use in the next part of the project. This is the part where we determine the effect against the Candida albicans. So we do the minimum inhibitory concentration, minimum fungicidal concentration, and the anti-biofilm formation at the sub-MIC level. All of this is controlled by the nystatin. For the human cell part, we will test the toxicity test of the extract for sure. And anti-inflammatory activity, we want to prove that it can reduce the inflammation that induced by the Candida supernatant. And we also use the LPS for the control too, for the control of the induced inflammation of the cells too. And we want to determine the pro-inflammatory cytokine levels for IL-1 beta, IL-6, IL-8, and TNF alpha. We also would like to try the infection assay to see whether if the our extract can inhibit the cell adhesion, the cell Candida adhesion to the gingival epithelium cells and inhibit them from invasion to the cell. So now, how do we apply our extract to the real clinical use? So right now we have the Electrospun. This is the project that will be collaborate between Faculty of Dentistry and the Faculty of Pharmacy in Chiang Mai University. Let's see what is the Electrospun. Actually, Electrospun is the nanofiber sheet. So this is the sample. It consists of the nanofiber that waver into the sheet. The process of producing the electrospun is called the electrospinning process. We're using the electric field to produce the very ultra-fine continuous nanofiber. And we use the high power supply to pull the polymer inside the silings and let them go to the collector at the opposite side. So the idea is that when we create the electric field, when the voltage is higher than the surface tension, it will pull the polymer solution here as the polymer jet, and the polymer jet will land on the collector as we see before, and then the solvent that dissolve the polymer will be evaporated and then leave the nanofiber at the collector. This is the real machine set that processed by the Faculty of Pharmacy. This is the high voltage power supply. And this is the silings that contain the polymer solution that we want. And also, if we complete the extract, the colloidal extract, we will mix the colloidal extract with the polymer solution in here. And when it ejects, it will carry the nanofiber along with the active component that we want into the collector. And when then it becomes a sheet here, the nanofiber sheet here will have our active component inside. This is another machine that they use. The difference is the collector has the collector can roll. I mean, previously the collector is just a plate, right? This one, the collector is it can roll so that it can collect a longer sheet. The nanofiber we use in here is the polyvinyl pyrrolidone. Since this is a material that has been used in the field of cosmetic and medical and the dental applications for quite a long time, so it has been proved that it has a low toxicity, it's good in biocompatibility, and it can adhere in oral cavity. This is another sample that we are using in the Faculty of Dentistry in Chiang Mai University right now. It's also the Electrospun sheet or the nanofiber sheet with the toluidine blue. We use this in our oral medicine clinic. So, as I said before, the Electrospun has been used in the dental application for a while. Like for the tooth regeneration, they put the stem cell inside. Also, for the guide tissue regeneration as a scaffold for the tissue regenerate. For implant modification, for cartilage regeneration. And our project is here. We are doing drug delivery to the oral cavity. So for the next part is that after we do after we successfully create the electrospan with the coriander seed or extract sheet inside, then we aim for the clinical trial in our oral medicine clinic. For my first target is that the patient with the dental stomatitis. As you can see, the patient with the dental stomatitis, they have the erythematous area, especially on the palate, right? So I plan to use the electrospun to apply on the tissue surface of the denture and then let them hold it in their oral cavity so that the active component can be released inside the oral cavity for during the time that they wear the denture. So this is the reference for my presentation. Thank you. If you have any question, please feel free to ask.
Okay, thank you. Interesting strategy to prevent oral candidiasis. Okay, now we are open discussion from the audience. The question is coming with it's the effect of the component of coriander specific to candida.
Sorry, yes?
Yeah. It's the effect of the components of the coriander specific to candida. Which component is the most specific to the antimicrobial effect of the candida?
Oh, I understand. The one with the most effect is the linalool, as I told before. That linalool has been proved with the several paper that has been published already that it has the most effect of all the component inside the coriander seed or extract. Yes.
Okay. And how about the effect on the other microbial, other microorganism?
Yes.
Such as oral bacteria?
Yeah.
Like
I have reviewed the paper about the linalool also. They has the effect against the other periodontitis bacteria also.
Oh, really?
Like a P. gingivalis or the AA, yes. Yeah, they also have the effect against them too.
How about the resident microorganism in the oral cavity?
Actually, I can say that it also have the effect against the residential, the normal flora. Yeah, they have some effect, but not as strong as the gram-negative effect. That it usually the pathogen, right? The gram-negative is a pathogen, so they have the strong effect against the gram-negative, but not much. It still have some, but not as strong to the normal flora. Yes.
Yeah, this component is just for the most strong effect on the pathogens for the oral cavity. Okay. And then the next question is from the audience. Is the effect difference? Do you have any differences between the antibiotic effect among candida species? The candida species has many types. So audience asks it's a different effect among the candida species.
Oh, right now we testing only one effect, ATCC. I cannot remember the exact number. We only test for with only one species first. Yes, but thank you for your suggestion. We plan to do with the other kind of the candida species too.
Okay, I see. Okay, the other species, other questions come in the Thailand. This traditional herbal medicine is common in the critical use. In the for the other treatments.
Actually, I don't see any paper that published about using this in the oral candidiasis yet, but they also use this active component, the coriander seed or extract in other kind of the medical treatment, as for example on the skin or somewhere else, but not on the oral candidiasis.
Oh, oral candidiasis is the first trial
yes.
by your research. Okay, next move to the question from me in the could you tell me the reason why you take this specific nanofiber scaffold to apply the herbal component on the oral cavity?
Actually, it's like a story because at first I'm doing the project just the part of the extract first and thinking of how can I use how can I apply this into the auto-medicine clinic that I'm working on, right? So at first, actually, I'm thinking of what about if we use as just the suspension and mouth rinse, but it's going to be a little bit inconvenient for the patient to carry with them. And then I have my friend at the Faculty of Pharmacy, and they said that they're working on something like this. So yeah, that will be interesting if we can apply through project together.
It's good for the fitting of the oral cavity. Okay, thank you very much. Interesting lectures. Okay, let's move on to the second speakers. Dr. Yu Si from Sichuan University in China. He has published many bone biology papers in high impact journal. Please start your presentation, Dr. Si.
Okay, thank you. Can you hear me?
Yes.
Okay, I will share my slides. Does it work for you?
Now it's not presentation mode. It's just for the
this
overview.
One.
Oh, okay.
Working?
Now, yeah. Now,
okay.
Now I'm working. Okay.
Okay. Thank you so much. Thanks for this warm introduction. It's my honor to share our story about the identification and regulation of skeletal-related MNICs in bone development and homeostasis. My name is Yu Shi from West China College of Stomatology, Sichuan University. As all known, bone diseases such as dysplasia of bone and teeth, bone defect, and heteropobic ossification increase the burden of life in patients. Take osteoporosis, for example. The patient with osteoporosis have less bone mass and higher fracture risk that happen in hip, vertebral, femur, and other bones. It is very common for people over 50 years old, and especially for the females. Treatment costs millions of dollars per year to manage conditions, but cannot fully cure it. It is widely accepted that osteoporosis was caused by the imbalance between osteoblast-mediated bone formation and osteoclast-mediated bone resorption. The defect of osteoblast function and the formation leads to osteoporosis. So you can appreciate here if the bone resorption is much higher than the bone resorption, there's a big hole in the trabecular bone region. They cause the osteoporosis. So osteoblasts differentiate from mesenchymal stem cell. We call this MSCs for short, that function to build bone. On the other hand, osteoclasts from HSC, which is hematopoietic stem cells, will take charge of eating damaged bone. Therefore, studies focusing on MSC fate decision are the cutting-edge topic in the field. So in our lab, we have been focusing on the topic for a while. So we are the interest of our lab is identification and regulation of MSCs. Previously, perinatal SOX9 positive cells, COL2 positive, aggregate positive cells, and the neonatal ostrix positive cells differentiate into osteoblasts and stroma cells in vivo. Recently, there's multiple big paper coming out demonstrate that bone marrow LAPAR positive cells are the main stem cell source in adult stage in mice. And another Nature paper report that CTSK labeled the MSCs in periosteum during intramembranous ossification. The trabecular bone is sensitive to osteoporosis. However, the source of osteoblast in this region remain unclear. Indian hedgehog is indispensable for osteoblast differentiation during endochondral bone development in the embryo. Indian global knockout mice is lethal after birth, therefore cannot be used for investigating the adult bone formation. Fortunately, there's a GLI1 inducible cray available for studying adult work. So GLI1 cray T2 mice express a tamoxifen inducible cray from the endogenous GLI1 locus. So take advantage of these mice. We ask, does GLI1 mark postnatal MSCs in long bone. To this end, we cross GLI1 Geriatric mice with Rosa26 TD tomato reporter mice. In the presence of tamoxifen, Cray removed the stop cassette and TD tomato will be expressed. The whole cell turned to be red. So we named them GLI1 positive cells. To demonstrate these GLI1 positive cells can give rise to osteoblast, we generate GLI1 Geriatric TD tomato COL1 GLP mice. In this mice, osteoblast and osteocyte can express GLP. One day after tamoxifen administration, less than 10% of the GLI1 positive cells underneath the growth plate co-expressed GLP, indicating that most of the GLI1 positive cells at this time were not mature osteoblasts. However, after 1 month chasing, more than 80% of GLI1 progenes now express GLP, which suggested that the newly formed osteoblasts are from GLI1 positive cells. To functionally investigate whether GLI1 cells are critical to trabecular bone formation, we cross GLI1 Geriatric mice with Rosa26 Diphtheria toxic A mice. In the presence of tamoxifen, GLI1 positive cells were depleted due to the expression of cytotoxic DTA. So we performed micro CT. So you can appreciate here, after GLI1 cells depletion, in the DTA group, the bone mass was significantly decreased. And bone formation serum marker PONT was also reduced in the DTA group. However, osteoclast serum marker CTX1 remained normal. So with this, we know that the postnatal GLI1 positive cells are important for bone formation, but not for bone resorption. So in vivo, besides osteoblast, GLI1 positive cells can also differentiate to both adipocyte and bone marrow stroma cells indicated by perilipin staining and LIPARP immunostaining. Furthermore, to prove GLI1 positive cells are truly MSCs, we also perform RNA sequencing experiment. After data analysis, we found several MSC marker genes were enriched in GLI1 positive cells, such as CD106, CD146, alpha SMA, LIPAR, PDGF receptor alpha and beta. The immunostaining with PDGF receptor alpha and factor analysis also confirmed this finding. Importantly, during bone fracture healing of the femur, you can appreciate that GLI1 positive cells and their progenes were involved in both soft callus, indicated by aggregate staining, and the hard callus, which indicated by staining 10 days after fracture procedure. So with this, we can conclude that GLI1 labels MSCs in trabecular bone, and GLI1 positive cells differentiate into osteoblast, adipocyte, and bone marrow stroma cells in vivo. GLI1 cells are the main source of trabecular bone formation and maintains the bone homeostasis. Importantly, GLI1 cells are indispensable for bone fracture healing. So after that, we are asked, how are the GLI1 positive cells regulated during bone formation? So we know that PTH is a potent stimulator of bone formation. Teriparatide or human PTH1-34 peptide has been FDA approved for the treatment of osteoporosis in postmenopausal women who are at high risk for fracture. Several studies have been shown that PTH increase osteoblast and bone lining cell activity. And PTH can also inhibit osteoblast apoptosis and prevents adipogenesis in the bone marrow. However, whether PTH target on MSCs remain not clear. To address this question, we first treat the GLI1 Geriatric TT tomato COL1 GLP mice with tamoxifen at 1 month of age, followed by 21 days PTH administration. Our data demonstrate the PTH significantly increased bone mass indicated by macro-CT. Importantly, the GLI1 positive cells will respond to PTH and expand on the surface of newly formed trabecular bone. Then we take a close look and found that short PTH administration increased GLI1 cells proliferation and osteogenic differentiation, indicated by proliferation-specific marker EDU and the osteogenic marker ostrix staining, respectively. However, in these two conditions, the apoptosis were not altered. In order to figure out which cell subpopulation that mediate PTH increased bone formation, we also performed single-cell RNA sequencing with GLI1 positive cells. There are at least 4 subgroups of GLI1 cells, and among there, the chondrocyte-like osteoprogenitors, because COP for short, were co-expressing the chondrocyte-specific marker SOX9 and also osteoblast specific marker RANK2 and SP7. Interestingly, the PTH expanded the COP cluster, and the trajectory prediction based on SOX9 or aggregate expression revealed a temporal progression of COP to other clusters. To test directly the computation prediction of COP as osteoblast progenitor, we use the aggregate CRE-ERT2 mice that express CRE-ERT2 from the endogenous aggregate gene locus, and therefore expect to mark the COP upon tamoxifen administration. So you can appreciate here, after 2 months, after 2 weeks, many aggregate COL1 double positive cells were detected within the trabecular bone region. The lineage tracing experiment here therefore confirmed the prediction from trajectory analysis that COP is an osteoblast progenitor. Our previous data had been shown that hedgehog can bind to patch1, which release the inhibitory effect of smoothing. Therefore, facilitate GLI2 full-length activator translocated into the nucleus and then initiate gene expression. And here, IGF-1 and 2 were demonstrated as hedgehog directed target. In turn, the increase of IGF activate phospho AKT in mTORC2 pathway and stabilize GLI2 full-length protein. Therefore, our data demonstrate that hedgehog GLI1 and IGF play a reciprocal function and mediate the osteoblast differentiation. So in this study, we introduced GDC drug, which was an antagonist of smoothing, and to inhibit hedgehog signaling. So bone mass was increased after 10 days of PTA treatment, which were significantly diminished by GDC administration, indicated by both micro-CT and H&E staining. So this phenotype was due to the decreasing of proliferation and osteogenesis of GLI1 positive cells upon GDC treatment. So next, we generate the GLI1 CRE-ERT2 IGF-1R CKO mice in which IGF signaling was blocked in GLI1 positive cells upon tamoxifen administration. So here is our regimen. So as data shown here, IGF-1R depletion dramatically abolished PTH increased bone formation and leave bone resorption normal indicated by serum P1NP and CTX serum assay. So furthermore, PTH-induced proliferation and differentiation were also detected in both wild type and CKO mice. The quantification of double positive cells were decreased in CKO group, indicating that IGF pathway was indispensable for PTH anabolic effect on GLI1 positive cells. So with this, we conclude PTH promotes proliferation and osteoblast differentiation of GLI1 positive cells. Single cell RNA sequencing uncovered chondrocyte like osteoblast osteoprogenitors among GLI1 cells. And the COP are the target of PTH. So hedgehog and IGF signaling in GLI1 positive progenitors mediate the anabolic effect of PTH. So with this, I will thank Dr. Fan-Xin Long from University of Pennsylvania in the United States and Dr. Ling Yan from Sichuan University in China, and also thank for the support from my grant. With all this, I will thank for your attention, and I'm happy to take any questions. Thank you.
Okay, thank you, Dr. C, for your exciting talk. Now we are open discussion from audience. Do you have any questions from the audience? Okay. Okay, the one question coming, do GLI1's positive cell also contribute to the craniofacial development and regeneration?
I think the answer is yes. Previously in cell stem cell and another Nature Cell Biology paper, another researcher published that kind of data. Indeed, GLI1 positive cells in the suture, and also the cells in the scissor contribute to fracture healing. I think the answer is yes. Thank you.
Okay, it's not specific for the endochondral ossification, but some craniofacial development.
Yes.
Involved. Yeah. Okay. Thank you. Any other questions? A question coming, the pre-treatment of hedgehog is possible before the PhD treatment in the osteoporosis as a treatment?
So you want to treat
do you think about pre-treatment of hedgehog?
Okay. I think hedgehog signaling is have a very widely functional during the development. It's no matter. I mean, it's not just limited in the bone formation. It's also have other function in the tumor genesis and the neuron science. So if you want to treat the cell with hedgehog alone, I think they will have some side effect.
Okay. See. Okay. Any other questions coming? Okay, time is almost coming. Thank you for the exciting lecture again. Okay, let's move on to the next final
speakers. Thank you so much.
Thank you for very much. Let's move on to the final speakers. Dr. Jun Watanabe from the Tohoku University in Japan. His title is Dispersion of the Aerosol and Droplet in Different Dental Procedures. Please start your presentation, Dr. Watanabe.
Can you see my slide?
Yes, yeah, please start.
Okay, thank you for your introduction. First of all, it is my great pleasure to have an opportunity to speak at this symposium. Sorry. I'm Jun Watanabe with Tohoku University Hospital. The title of my presentation is Dispersion of Aerosol and Droplet in Different Dental Procedures. I would like to talk about the current aerosol findings in the first three sections. As you know, COVID-19 caused a severe pandemic. Severe acute respiratory syndrome coronavirus 2, called SARS-CoV-2, is present in saliva at concentration comparable to nasal mucus. CDC in the US had listed dental care related aerosol and or droplet as a high risk based on presumed equivalent of this aerosol as much as during medical procedure. In the dental setting, the risk of transmission might be related primarily to the treatment of asymptomatic and minimally symptomatic patients. Therefore, aerosol and droplet generated during dental treatment have gained attention. What is a dental aerosol? A dental aerosol is an aerosol that is produced from dental instrument, dental handpiece, three-way syringe, and other high-speed instrument. This aerosol may remain suspended in the clinical environment. Dental aerosol can pose risk to the clinician staff and other patients. The heavier particles, more than 50 micrometers contained within the aerosol, are likely to remain suspended in the air for only short period and set quick onto the surface. However, the lighter particles may remain suspended for longer period and travel some distance from the source. The recent accepted use of the term in infectious disease research includes only particles below 5 micrometers. Next, I would like to share about the features of dental aerosols. As you can see in this fluorometric heat map figures, aerosol produced by dental procedure can be detectable at distance of more than 5 meters in open clinic after 10 minutes. Endodontic treatment detected aerosol-like microorganism at 2 meters from the patient mouth. Moreover, aerosol contaminated with blood was detected at 1 meter to extract an impacted third molar using an air turbine. Aerosol were detectable at least 15 minutes after use of the air turbine without proper ventilation or suction. Furthermore, the aerosol remains in the air up to 30 minutes after scaling. The aerosol particle generated from tooth preparation and predominantly 1 to 2 micrometers in particle size. Particles smaller than 3 micrometers are generated far more abundantly than larger particles, and then smaller particles smaller than 3 micrometers are transported more efficiently more than larger particles. And these aerosols may consist of particles from saliva, blood, dental plaque, caliculus, tooth debris, oil, and microparticles from grinding of the tooth or dental materials. Uesaka reported that dental aerosol contains silicon, calcium, potassium, barium, and zinc. Interestingly, the aerosol density aerosol density was higher in the prosthodontics department than in the conservative department. On the other hand, alpha hemolytic Staphylococcus was the predominant bacteria produced during oral surgical procedures in the aerosol. The Staphylococcus aureus, Enterococcus faecalis, Pseudomonas, and Escherichia coli were also detected in dental aerosol. Some previous reports indicated that tooth position, instrument, and procedure can influence bacterial distribution during treatment. How about contamination by dental aerosol and splatter? During dental practice, central areas of the face, such as inner part of the eyes and around the nose, were most contaminated areas. The facial area of the assistant, as well as the operator, is severely contaminated by splatter and aerosol, regardless of the procedures. Next, I would like to introduce conventional aerosol measurement method. The most commonly used measurement approach is a pigment or fluorescence dye. They have the advantage of the measuring the range, velocity, and particle size. However, aerosol, this method are not applicable to human bodies. That's why this method cannot be used to evaluate actual dental procedures. Bacteriological approach and particle counting method are also commonly applied. However, this method cannot directly analyze aerosol dynamics. In recent years, computational fluid dynamics called CFD approach have also been applied. However, current CFD have limitation of not simulating the flow perfectly. Therefore, we focused on the new technology using a high-speed digital high vision camera and LED laser technique. This method has the advantage of measuring the treatment directly without dye and analyzing the aerosol range and velocity. Based on this background, the purpose of this study was to establish a novel aerosol measurement method using a high-speed camera and mesh process technology, and to investigate the effect of different treatment site and instrument on aerosols and droplet generation, and to determine the optical condition for extraoral high volume suction. As you can see in these panels, the experimental setup were prepared in a regular dental operatory. To simulate the patient, a mannequin head was used in a spine position of a dental chair. The images of the dental aerosol were taken and recorded by digital high-speed video system. The images were taken from the lateral position, vertical to the direction of the dental procedure, main forward movement, with lightning by LED laser in a dark field. The obtained images were processed pseudo color using Photon fast scan viewer software. High brightness area was displayed in red and low is blue. You can see the distribution and the spread of the whole aerosol in this method. Aerosol area was measured with Fiji software after calibration with measured values and binarization. At first, this figure showed aerosol diffusion areas significantly increased in round and butt shape at upper incisor. This result means butt shape is one of the factors in aerosol generation. Next, we examine the effect of tooth position and plane in air turbine handpiece on aerosol and droplet diffusion. As you can see in these panels, aerosol diffusion increased significantly on the palatal plane of the maxillary anterior teeth in air turbine. The ultrasonic scalar device showed a similar tendency. It means with the maxillary anterior teeth showed the highest aerosol diffusion. Finally, we evaluated the effect of intraoral suction and extraoral suction in air turbine handpiece on aerosol and droplet diffusion. As you can see in these figures, without suction group, the aerosol diffusion increased dramatically. In contrast, use of intraoral suction and extraoral suction reduced aerosol diffusion by more than 90%. Okay, I show videos about this experiment. On the left side is without suction, and the right side with intraoral suction and extraoral suction. You can see the use of IOS and EOS group dramatically reduced the diffusion of aerosol and the splatters. And finally, I investigate the effect of position of extraoral suction on aerosol and droplet diffusion. This result suggested that position of extraoral suction is one of the factors in reduction of aerosol diffusion. Okay, let's move on to the discussion. The correlation between image brightness and particle size was unclear in this measurement method. Therefore, it is difficult to distinguish between splatters and aerosol. We expanded the imaging range to measure the capacity of droplet diffusion. It is challenging to observe smaller particles below 1 micrometer. In aerosol dynamics measurement, it is required to use a seed laser beam with limited range and measure the side scatter right instead of forward scatter right. In conclusion, we successfully in establishing a novel dental aerosol measurement and image analysis method. The most extensive droplet diffusion range was observed with an air turbine on the maxillary anterior teeth. A vertical extraoral suction might prevent the diffusion of aerosol and splatters. Thank you for your attention.
Thank you very much. Very interesting talk for the, this is very relevant and timely for the clinical practice and education and this COVID pandemic situations. Okay, now move on to the open discussion from audience. Do you have any questions for him? Okay, I have the questions about this is my just curiosity. How much bacteria inside in the one aerosol particle?
Thank you for your question. It is previous report contains the alpha hematotic Staphylococcus was the predominant bacteria, and C in the CFU unit, over 6 CFU per milliliter is contained in one particle.
Okay, the oral cavity is have a much amount of the oral bacteria other than the the surface of the body. That's why the to prevent the spread of the dental aerosol is most important. The most important thing to infection control. Okay. And any questions? And okay, from the audience. By your imaging method, what size of aerosol can be detected?
Sorry.
By your imaging method, what size of aerosol can be detected?
Thank you for your question. Actually, in this experiment, we cannot distinguish the size of particle, but previous report showed that in sneezing and cough experiment, the below 1 micrometer particle can be detected in this method. So maybe this result contained maybe 0.5 from 0.5 micrometers particles in these images.
So you mean you can distinguish the different size of particle from the dental aerosol using this method?
Yes, for distinguish the aerosol particles, maybe we need more high resolution and high magnification images. So in this time, I focus on the whole range of the aerosol diffusion. So maybe we need more study to investigate.
If you focus on the more the specific area, you can distinguish the particle size using this method.
Yes.
Okay. Another question is coming: how to realize the extraoral vacuum in the clinic, and how to realize the extraoral vacuum in the clinic.
How to
realize how to. Okay, maybe okay. See how to the extraoral vacuum in the clinic. Maybe the high speed. Sorry, let's move to the next question. The high speed, if the high speed is pressed inside the mouth during the experiment, the person
in this time, I measured high speed camera at 1000 fps, but this camera can detect over 30,000 fps. So maybe the data volume is very high, but we can observe more high resolution and high fps images using our method.
Okay, it's one comment is coming is the aerosol size is few micrometer in diameter, so it's not so many bacteria can be contaminated. But if the aerosol is volume of the aerosol is increased, the risk is increased. Okay. See, any other questions? Okay, thank you for the interesting talk from the Dr. Jun Watanabe. And now time is coming. We are closing this session. Thank you for joining this session and enjoy the later program. Thank you very much.
Thank you so much. So now we will move to keynote session 2, the Shokugaku research. The chairperson of this session is Professor Hiroyasu Kanetaka, Tohoku University.
Thank you, Dr. Kusama. Good afternoon, distinguished colleagues and friends. Thank you very much for joining this session, Keynote 2. I'm Hiroyatsu Kanetaka, Professor and Chair, Division for Interdisciplinary Integration at Tohoku University, Graduate of School of Dentistry. The session focused on Shokugaku. I think the most audience will hear the first Shokugaku for the first time. So let me briefly explain about Shokugaku. Shoku means eating or food. Gaku means science. In 1990, Tohoku University Graduate School of Dentistry created Shokugaku as the world's first transdisciplinary science of eating, food, and nutrition for promoting health and well-being through right eating and right food. In collaboration with Tohoku University Graduate School of Agriculture and Miyagi University. Professor Takahashi, the first speaker of this session, will give a detailed explanation about Shokugaku. So if you have any question about Shokugaku, please ask Professor Takahashi at discussion time. In this session, we have 4 speakers. First of all, Professor Takahashi will give a lecture on Shokugaku. After that, Professor Kamiya will give a lecture on food science. Professor Ishikawa will give a lecture on nutrition. And Professor Tanaka will give a lecture on dentistry. After each presentation, we will accept questions from the audience. If you have any questions, please write your questions in the chat box. Now, we're going to start with presentation by Professor Nobuhiro Takahashi. Professor Takahashi is currently Dean of University Graduate School of Dentistry. The title of the presentation is Transdisciplinary Science of Eating, Food, and Nutrition. Professor Takahashi, please start.
Thank you for your kind introduction. Can you
yes.
Can you hear my voice and
yes,
see my
presentation?
Hear you well.
Yes.
It's okay? Is it presentation mode?
Yes.
Okay. Good afternoon, everyone. I'm Nobuhiro Takahashi, Dean of Tohoku University Graduate School of Dentistry and Professor of the Division of Oral Ecology and Biochemistry, Tohoku University Graduate School of Dentistry. Thank you very much for taking time out of your busy schedule to gather here today for the keynote symposium, the Shokugaku, or the transdisciplinary science of eating, food, and nutrition. As already introduced, sorry. It's okay. As introduced already, this symposium will feature 4 speakers presenting on a new discipline called Shokugaku. As one of the founders, I'd like to explain about Shokugaku in my presentation. My presentation today will focus on the 4 items on this slide. 1, what is Shokugaku? 2, the topic covered in Shokugaku. 3, significance of Shokugaku in dentistry. 4, overview and procedure of Shokugaku. So this is going to be a very short presentation for about only a few minutes, but I hope you can understand the meaning and significance of this new discipline, Shokugaku. Now, I will start my talk. One is, what is Shokugaku? This is the first new transdisciplinary science that integrates oral science with existing discipline, food science, and nutrition science. In 2020, Tohoku University Graduate School of Dentistry, in collaboration with the Tohoku University Graduate School of Agriculture Science and Miyagi University School of Food Industrial Science, launched the concept of Shokugaku and established the Innovative Research and Education Center as a base for conducting this new science. Shokugaku is a new Japanese word that combines shoku and gaku, as Professor Kanetaka already talked. Gaku is like this in Japanese or Chinese word, which means the field of study or discipline. So shokugaku means the discipline of shoku. And then what is shock? So shoku is also Japanese or Chinese word, and meaning everything relating to eating or function, food, and nutrition. However, we cannot find a suitable English word for this comprehensive meaning. So we prefer to calling this new discipline as shokugaku, as it is. When translated into English, it's become a long descriptive name, transdisciplinary science of eating, food, and nutrition, or shortened TFON or something like that. The goal of shokugaku is to realize lifelong health and well-being through light eating and light food. So what are the contents of the shokugaku, the topic covered in shokugaku? One is oral function science, which covers the sensing of eating, including chewing, swallowing, and so on, and the sensing of tasting, and including taste and smelling, and the texture, and so on. And the second is food science, which deals with the research and development of new functional food and disaster food based on new technological innovations. 3, nutrition science, which deal with the discovery and creation of new functional food molecules, as well as meticulous individualized nutrition according to each person's age, constitution, and health condition. These 3 will be the basic science of shokugaku. In addition, 4, shokugaku-based microbiome science, which deal with the food-induced modification of oral intestinal microbiome and modification of food components and new functions induced by oral and intestinal microbiome. 5, shokugaku-based data science, which deal with the cohort study of eating, health, and well-being. So they will be the transdisciplinary in many sections, including academia, industry, and government. Then, based on the traditional transdisciplinary co-creation, we will develop a new functional food that bring about health and well-being, and create eating programs for lifelong health and well-being. To utilize these results in society, the social co-creation, including industry academia collaboration, social demonstration, and social implementation is essential. Finally, we will realize a society with health and well-being by enjoying eating, even in a super age society and disaster situations. Now, let's shift our focus to dentistry and consider the significance of shokugaku in dentistry. In 2002, just 20 years ago, Tohoku University Graduate School of Dentistry created a concept of interface oral health science that became the redefinition of the oral cavity in dentistry. We need to redefine the oral cavity in dentistry, because at the time, the dentistry was still just a set of small sections of dental things such as basic dental science, including oral anatomy and biochemistry and so on. and also cardiology and periodontology and prosthodontics and so on. Therefore, we strongly think that we have to construct dentistry as one of the independent disciplines, which should be equal to a medicine or engineering. To realize this first, we need to think again that what the oral cavity is. That the oral cavity is one whole, and ask again what the oral cavity is. Our answer is the interface oral health science. According to this concept, the oral cavity consists of 3 components: host, such as teeth, tongue, mucosa, and bone, and parasite, a tremendous number of microorganisms living in the oral cavity, and biomaterials, which are utilized for dental treatment. And the strong and complex mechanical stress are loaded onto these components. So it's important to know that dental disease and disorder always occurs at the interface between these components. For example, dental caries and periodontitis occur at the interface between the host and parasite. In addition, the oral health is promoted by the interaction with society, so we added so-called social interface here around the circle. Well, furthermore, this concept has helped us to recognize both the uniqueness and universality of dental science. And this is currently the basis of interdisciplinary, international, and practice-oriented dental research and education at our school. So based on this concept, we are now collaborating as one of the independent disciplines with many other disciplines, such as engineering, medical engineering, material science, environmental science, and so on. However, in the past 20 years, we recognize that the role of dentistry has been expanded from the prevention and the treatment of oral disease to the promotion of oral and systemic health. Since eating is the most important factor for the promotion of health and well-being, dentistry has a responsibility to conduct Shokugaku as a discipline of the oral cavity, the gateway to food. From this perspective, Shokugaku will be one of the lead definitions and the new mission of dentistry in the future, which aim to promote oral and systemic health and well-being. At the same time, domestic exchange in Japan is also accelerating the creation of Shokugaku. There is an urgent need to realize a health society with longevity. There is also an inevitable need to secure healthy food in times of, even in the times of disaster. As you know, Japan is one of the countries where natural disaster occur very frequently. However, there is no such food product and eating program to achieve healthy longevity through eating and by mouth and eating well. As a background, we have been facing a super aging society and have to be reform of primary industries. And also, as I already said, Japan is one of the frequent natural disaster country. So it is very important to note that the domestic conditions in Japan will also everywhere in the world in the future. So in this sense, Shokugaku can be the pioneering discipline that anticipates the challenge of the world. At the same time, it is also be a great opportunity finally include food science and nutritional science, which has not been included in dentistry and medicine in Japan. So these food science and nutrition in 2 curriculum of dentistry and medicine. Shokugaku will shift medical and dental care to more proactive prevention, disease control, and health promotion, enabling the revitalization of the super aging society that humanity will soon face around the world. So let's take a look back at the whole process of Shokugaku step by step. So as I have already mentioned, Tohoku University Graduate School of Dentistry and the Graduate School of Agricultural Science and Miyagi University have collaborated to integrate these disciplines of oral science, food science, and nutrition science to study new discipline Shokugaku. Shokugaku is the world's first disciplinary science of eating food and nutrition for health and well-being. These new disciplines are activated by transdisciplinary co-creation of academia, industry, and government, and so on. Next, based on the result, we will develop new functional foods and disaster food that promote oral health, overall health, and well-being, especially based on the industry academia collaboration. We'll also develop lifelong food program that applied these food. Furthermore, we will promote social creation by implementing these food program in society, conducting social demonstrations and making them take root into the society. The goal of Shokugaku is to realize healthy and happy life by eating good food anytime and anywhere, or in other words, even at a very old age or in time of disaster. So furthermore, by taking total view of medicine, health, and welfare, Shokugaku can be expected to shift prevention and treatment to more proactive measures against pre-disease and promotion of health and well-being and sustainability, revitalize the super aging society that humanity will face in the near future. Shokugaku transdisciplinary science of eating, food, and nutrition, which promote lifelong health and well-being through light eating and light food. This will also create a new science for health and well-being as a mission of dentistry. That's all my presentation of the new discipline Shokugaku. I'm sincerely looking forward to your understanding, support, and participation this Shokugaku. Thank you very much for joining us today and very kind attention. Thank you very much.
Professor Takahashi, thank you very much for your informative and fascinating presentation. Now, the floor is open for discussion. Are there any comments or suggestions or questions from the audience? We accept the questions from audience. So may I ask you a question?
Yes, please.
Yes. Recently, the microbiome is attracting attention in health or food development field. So how would you like to apply your skills about microbiome to Shokugaku?
Well, thank you very much for a very important question. Actually, I'm studying on the oral microbiome, and especially the metabolic activity of the microbiome. So already there's many reports about reports that some food component can be metabolized by the oral microbiome to convert to the bioactive component. For example, nitrate contained in the vegetable can be converted to nitrite by oral bacteria. So nitrite is a kind of a component to normalize blood pressure. So this kind of component contained in the food can be developed. Then, then we can control the interaction with the oral microbiome to create more healthy-oriented component in the oral cavity. This is one of the ways to contribute my skill to the Shokugaku. The other hand, some food can modify microbiome itself. So as you know that the microbiome profile is closely related with oral health and general health. So if we can control the microbiome by food, so maybe we can improve our healthy conditions. So this is also another way to contribute our skill, my skill to contribute to the Shokugaku, I suppose. Thank you.
Thank you very much. Very informative answer.
Thank you.
So due to time limitation, I'll close Q&A session at this point. Thank you again, Professor Takahashi.
Thank you very much.
So let's move on to the next presentation. The next presenter is Professor Tetsu Kamiya from the Tokyo University Graduate School of Agriculture and Nagase Corporation. The title of the presentation is The Novel Visualization and Evaluation Methods for Swallowing Process and Dynamic Food Bolus Properties. Professor Kamiya, please start.
Can you hear my voice?
Yes, I can hear you well.
And also you can see my presentation
Yes,
material. Sorry,
but not slideshow style. Yes. Okay.
It's okay.
Yes. Yes, please.
Okay. Thank you, Mr. Chairperson, and good evening, everyone. I'd like to thank for the invite me today to the presentation. So I came from Nagase, a new value creation office. The title is today's topics is a novel visualization and evaluation method for swallowing process and dynamic food bolus properties. First of all, I'd like to tell you that all research work is collaborated with the Dr. Yukihiro Michiwaki, Musashino Red Cross Hospital, and Meiji Corporation Corporated. This is my job. So today's outline. So first of all, I'd like to talk to the background and the motivation of this work. For example, the position in the Shokugaku research field in my research work, and key factors of the evaluation in Shokugaku. The next topic is computer simulation, swallow vision, a novel numerical simulation system for human swallowing. And I'll give you some latest information of the swallowing results, such as the physical property during the swallowing and visualization of the bolus configuration. The next topic is dynamic experiment system originally developed. F-Bolology Analyzer, a dynamic bolus flow measurement system, and oral maps, and also an artificial bolus formation system. And also I will give you the key result of the dynamic experimental system, such as a comparison with sensory evaluation, and the salt content behavior in the artificial saliva during the mastication. Finally, I will give you the take-home message and talk to the future work. So first of all, I'd like to talk to my research work position in the Shokugaku research field. As Professor Takahashi and Kanetaka professor already said, the Shokugaku defined as the transdisciplinary science and food, eating, and nutrition for health and well-being with co-creation. In case of my research field, I will have focused on oral science, for example, mastication and swallowing, and also food science, the sensory and physical properties, and engineering. My background is mechanical engineer, so the modeling and computer simulation and some sensing and monitoring system is based on the engineering knowledge. This is my research work position within the Shokugaku. And next, I explain the key factors of the evaluation is Shokugaku. This is my opinion. Yes, there are 4 important key factors to evaluate the Shokugaku field. First important key factor is visualization to qualitative understanding. Next key factor is numerization. The qualitative understanding is required in the several physical property or action of the swallowing and mastication. Third key factor is prediction, the future or case study for the several situation. The last key factor is connection. Connection means a link to one's own issue. Based on these 4 key factors, we will realize the tailor-made food design, program development in lifetime, and the safety assessment of the food and for the elderly person or swallowing disorders or several aging segments. So the next topic is the computer simulation. Swallow vision, a novel numerical simulation system for human swallowing. The swallow vision has 4 important technical components. The first important technology is modeling of the human organ configuration and movement. 3-dimensional model is created by CG software based on the CT images, video fluorography images, and anatomical knowledge with the Dr. Yukihiro Michiwaki. So first of all, the static human organ model have created. Then based on the VF images like this, so the static model add some action to the swallowing configuration changes or something. Finally, we'll make the dynamic 3D model. Second important technology is modeling of the food porous property to measurement to use the measurement and experiment the physical model of the fluid dynamics and the physical property of food, such as living organ surface, contact angle, and so on. The third important technology is integration of organ and bolus model into the simulation solver. Swallow vision is based on the 3-dimensional moving particle simulation system, MPS method. The fourth important technology is verification and validation. For the without verification and validation, simulation result is no meaning, just a CG. So this is a validation or one difference of the validation result compared with the VF image and simulation system. The VF image simulation is completely similar behavior during the swallowing. So several validations have been carried out. So I will share you the latest information of the swallow vision. This is the image of the comparison of the flow pattern with water and thickness. Left-hand side movie is flow pattern of the water, and right-hand side is a flow pattern of the thickness, non-Newtonian fluid. You can see in the case of water, like this, the small particle occur during the swallowing like this. So this is the cause of the aspiration during the swallowing. But in case of the thickness, during the swallowing, there are no small particle occur. That's a reason. It is easy to qualitatively understand the reason why the thickness is much easier to swallow than water. This is a qualitatively understanding method. Next key result is the swallowing with solid or elastic body. Elastic body means that gummy, jelly, cheese, and package like film. And also the swallow vision can calculate the solid parts. Solid to mean the nuts, candy, snack, and tablet, and package screw cap. In any case, the swallow vision can simulate the elastic body, solid, and water, same platform. This is the one strongness in the swallow vision. So next key result is the Numerize. This graph shows the comparison of the shear rate profile with water and thickness. The vertical axis is shear rate, horizontal axis is elapsed time, and the color is the frequency of the how many times that this shear rate occurs during the swallowing. The water, in case of the water, the peak is based on the dark color. Dark color means the lower frequency. And the distribution is wide like this because the small particle occur during the swallowing that means the small particle is very high speed. That's the reason the distribution, shear rate distribution is wide. On the other hand, this is in case of the thickness, non-Newtonian fluid. Compared with the water, the peak and much higher, because higher means a much lighter color, and the distribution is narrower than the water. This is a numerical result. Not only the visualization, but also Numerize is very important to compare with the numerical data. And also, this is a Numerized result. Graph shows the relationship between the holes on the each organ on the bolus position. The color is a part, for example, red is hard palate, blue is tan, green is soft palate, and pharynx, larynx is simulated. Yes, this is a host. The swallow vision can calculate and estimate the false information during the swallowing, the magnitude, direction, and the timing. This is one result. So the next slide shows a case study of the effect of the wall wet condition, dry or wetting condition. The all movement is same, and the physical property of food is same. Only different thing is the wettability of the boundary condition. Boundary condition means the wettability of the human organ surface. Case 1 and case 2 is excess wetting condition, like a skate rink. And also the case 4 is excess drying condition, like elderly person, the surface, or after some sports. The case 3 is a normal swallowing. The simulation is clearly indicated that, yes, the excess wetting condition is hold bolus is rapidly achieved to the voice hold, that you can see some particles have swallowing and aspiration occur. Then swallowing process is forward. Yes, so swallowing is finished, but the excess drying condition, you can see several remaining in the near the epiglottis and epiglottic barrier, not esophagus. This means yes, mis-swallowing occur after swallowing. This is a case study. Swallow vision can estimate the swallowing behavior, changing several physical property or wetting condition and so on. The next topic is dynamic experiments. Says, I will introduce two types of the dynamic experiment system developed by own R&D centers, F-biology and oral maps. The key feature of the F-biology, FBA, a dynamic bolus flow measurement system. The important component is a pseudo human organ on the inclined plate like this. Yes. And also the very high accuracy supply pump is installed in the system. And the several laser sensor is located on the several part like this. They measure the bolus arrival time on the thickness of the bolus and width of the bolus during the flow through down to the plate. And also 2 camera is installed in the side and top view to check the dynamic contact angle and the diffusion area. And all data has stored in the computer and processed. This is an overview of the epidemiology analyzing system. And also this is an engineering modeling of bolus tip and the physical quantity in epidemiology. This movie is real movies. The yogurt is flow down in the inclined plate. This red line is a laser location. The blue line is a laser measure the thickness on the and the width of the food bolus. And inclined plate, the food bolus is modeling like this. This is the classical physical problems. So due to the measuring the bolus tip speed and average velocity and the lower part and the upper part, so we will calculate the average frequency, average friction force. Based on this friction force, we can calculate work, power, impulse, shear stress, and several physical quantity from the FBA system. This graph shows the relationship between the sensory score and the output of FBA. Swallowing easiness, in case of the swallowing easiness, vertical right hand side is a sensory score. Vertical right hand side is impulse from the FBA. The sample A and BC, the sample A is a much highest value, highest score in the swallowing easiness. And sample C is lower swallowing easiness. The same trend in the impulse in the FBA. And also fine texture on the tan, the sensory score is sample A is the highest and sample BC is similar. Same situation in the diffusion area from the FBA. Also thickness in the oral cavity. The sample B is lowest. The same trend is shear stress. Some physical property quantity calculated from FBA are similar trend of the sensory score. We can consider the meaning of the sensory words from physical phenomena. Then the next system is oral maps and the artificial food bolus formation system. Then no meaning to the my explanation. So it's easy to understand the function of this movie. This machine make a bolus. For example, the trial sample for example, gelatin jelly. The homogeneous jelly is well mixed, and the heterogeneous jelly is just put in the salt in the surface. Then this graph shows the relationship between the mastication count and the salt content in saliva. Vertical axis is salt content in saliva. Horizontal axis is mastication count. Red circle is homogeneous one, and the triangle blue is heterogeneous. The tan feels the saltiness in the moment when the product touches the tan surface. Heterogeneous has stronger taste than that of the homogeneous. It's easy to understand, but this system can realize the numerical result. This is the oral maps performance. Now, finally, I'll give you the take-home message and the future plan. The idea of the tailor-made food design, I will carry out 3 steps. First step, we can use the swallow vision for personalized loop. The swallow vision can estimate the appropriate food property for target person. In this case, the swallow vision can estimate the aspiration prevent area like this. This area is aspiration prevent area. Then based on this curve, the researcher is try to make such flow curve like this. After that, this imitation food is measured by FDA. The final step is the evaluation loop, the given meaning of the designed food. Vertical axis is sensory evaluation value. Horizontal axis is FBA value. This case, several sensory evaluations were equal to have a linear relationship between the FBA model. This triangle is very important. Simulation, a real experiment, and sensory. This triangle is very important to the tailor-made food design. This is my final slide, take-home message. In my research, oral science, engineering, food science is concerning about swallow vision, ecology, and oral maps. And sensory and tailor food made design have been carried out. Near future, texture and structure analysis using the synchrotron lights is required and very useful, I think. And also nutrition will link in the near future. Finally, social co-creation and co-challenge, international standardization for safety assessment and well-being. Thank you for the kind attention.
Professor Kamiya, thank you very much for your excellent lecture presentation. The floor is now open for discussion. Are there any questions or comments from the audience? Any comments or questions?
May I have a question?
Yes, thank you much.
Thank you very much for your very excellent presentation. It's very interesting, especially the pseudo-human organs.
Yes.
Very interesting. So I'd like to know how you standardize or determine the parameters for simulation in this machine.
Good question. Simulation requires the physical properties and the boundary condition. Mainly the friction of the surface on the human organ. This is a parameter, fitting parameter. We will control to this fitting parameter you compare with the VF images.
I see.
So that's the reason. So it's very hard work.
Yeah, I think so.
To make an accurate simulation system.
So you collect a lot of data from the monitor, the VA system, and calculate it. Okay,
yes.
Thank you very much.
Thank you very much. Good question.
Okay, thank you.
Thank you. From the audience, any questions or comments? Professor Kamiya, may I ask your questions?
Hi. Yes.
Yes. Is it possible to use the both swallowing simulation called swallow vision and experimental experiment equipment as commercially used product or service?
Good question. So unfortunately, this is just only the research work, but within the 1 or 2 years, Yes, yes, within the 1 year. Yes, I will mean that Nagase will prepare to the some platform to use the simulation system by software as a service and the website cloud, and also the measurement environment we will make. This is my job.
We're willing to realize the system.
Yeah. Thank you very much.
If there are no more questions, I will close the Q&A session. Thank you again for Professor Kamiya. Let's move on to the next presentation. The next presenter is Professor Minoru Ishikawa from Tohoku University Graduate School of Life Science. The title of presentation is Chemical Biology of Bioactive Molecules. Professor Ishikawa, please.
Thank you, Professor Kanetaka. First of all, I'd like to thank Professor Takahashi and the organization for the opportunity of this presentation. I'm Minoru Ishikawa from Graduate School of Life Sciences, Tohoku University, We are also cooperative laboratory of Faculty of Agriculture. I have 3 topics today. First topic is about food bioactive ingredients, especially for prevention of dementia and personalized nutrition. Second topic is about our specialty, that is chemical biology, especially for target identification. Last topic is regarding our research, including degradation disease-related protein by synthetic molecules and recent effort to identify new target proteins of vitamin A. Recent science has yielded a basic understanding of key nutritional requirements for most humans. This resulted in one-size-fits-all approach, exemplified food guide pyramid. Food guide pyramid shows the food we should eat every day to stay healthy, and it has been impactful in reducing disease resulting from nutrient deficiencies. Nutrition is also thought to be important for disease prevention. I would explain an example of Alzheimer's disease, a major cause of age-related dementias. A typical process observed in Alzheimer's disease is aggregation of amyloid beta that would lead synaptic dysfunction and neuronal death. A reason that there are currently no cure for Alzheimer's disease would be long-term disease progression, probably over 20 years before the first symptom become obvious. Given the drug, when a person becomes a symptom, may be too late. Therefore, nutritional intervention of dementia is much important for prevention of Alzheimer's disease. According to risk reduction and cognitive decline and dementia by WHO, the Mediterranean-like diet may reduce the risk of cognitive decline and dementia. In addition, healthy and balanced diet is recommended. This slide shows the Mediterranean diet pyramid. It is said that the feature of Mediterranean diet is more fish, fruits and vegetables, grains, and olive oil, and less meat. The exact relationship between specific food ingredient and Alzheimer's disease development is not fully understood. However, some meta-analysis as shown here that fish intake and DHA intake reduce the rate of memory decline and the risk of Alzheimer's disease. DHA, docosahexaenoic acid, is the most abundant omega-3 fatty acid in brain. This slide shows the likely molecular mechanisms underlying neuroprotective effect of DHA. Neuroprotective effects are related to direct action on plasma membrane, amyloid beta, inflammatory response, and gene expression. These ingredients in olive oil are reported to show antioxidant activity and prevention of amyloid beta accumulation. So that means these compounds bind to aggregate. So these compounds are aggregate binder. Curcumin, an ingredient in curry spice turmeric, is another food bioactive ingredient that may be effective for Alzheimer's disease. It shows antioxidant activity and bind to amyloid beta and prevent aggregate formation. There are several human studies for Alzheimer's disease. I move on to the topic of personalized nutrition. Personalized nutrition is a diet recommendation that has been scientifically tailored to meet your personal nutrition requirement based on your genetic profile, microbiome composition, and environment exposure and personal wellness goals. One of the most popular personalized nutrition may be caffeine. Caffeine acts as an adenosine A2A antagonist and induces dopaminergic activities. And CYP1A2, this is a kind of metabolic enzyme, and CYP1A2 metabolizes caffeine in the liver, and CYP1A2 has SNP, single nucleotide polymorphism, leading to A2C substitution at position 163 and decreasing metabolic activities. Half of people are rapid caffeine metabolizers. Dasein, an ingredient of soybean, is metabolized to equol by intestinal bacteria. Equol is estrogen receptor agonist, which acts as a female hormone. Unfortunately, not everyone has enterobacteria that can produce equol. About half Japanese women can produce equol from dasein. Under such situation, equol supplement is available for women who cannot produce it. As I explained, food bioactive ingredients bind to the target proteins. So target identification, the process of identifying direct molecular target, is important for comprehensive understanding of mechanism of action of food bioactive ingredient. I will explain the molecular target of vitamin A. This slide shows vitamin A and the analogs. Retinol involved in vision, and all-trans-retinoic acid, ATRA, involved in growth and development. Vitamin A and the analog bind to many molecular targets. Red involved in biological function, greens are metabolic enzyme, and browns are carrier proteins. So affinity chromatography is one of the most widely applied methodology to identify the target of bioactive compounds. In detail, the bioactive compound is immobilized on the solid phase and exposed to protein extract to bind the target protein. Subsequently, non-bound proteins are removed by washing, and the bound protein is released by means of elution with the bioactive compound. The target protein is purified and LC-MS analysis. MS means mass spectrometry. Unfortunately, the success rate of target identification is quite low because food bioactive ingredients possess relatively weak binding affinity. And some food bioactive ingredient is insoluble in water. In addition, we sometimes encounter the results that the compound binds to the identified target protein, but not modulate its function. We call this kind of ligand as silent ligand. As for vitamin A, several lines of evidence as shown here indicates that there are unidentified target protein of vitamin A. An example of silent ligand is cellular retinoic acid binding protein, CRABP. A physiological ligand for CRABP is ATRA, and the biological activity as shown in red are expected to be a molecular target of anticancer agent. However, some of these activities are ATRA independent. For example, CRABP2 is associated with migration of neuroblastoma cells independent of ATRA. I move on our work. As an application of silent ligand, we are developing targeted protein degradation. I will introduce CRABP degraders utilizing vitamin A and degrader of neurodegenerative protein utilizing aggregate binder. And I will introduce a recent effort on target identification of food bioactive ingredients, including vitamin A. To develop a novel strategy for targeted protein degradation, we focus on ubiquitin proteasome system. Intracellular protein substrate is recognized by ubiquitin ligase, and the protein and necessary protein is ubiquitinated and degraded by proteasome. If it is possible to form an artificial complex between the ubiquitin ligase and a target protein instead of protein substrate, the target protein might be also ubiquitinated and degraded by proteasome. And to form such kind of artificial complex, a hybrid molecule consisting of ligand for target protein and ligand for ubiquitin ligase would be effective. A strong point of this method is we can utilize silent ligands. To proof of concept, we selected CRABP as a target protein. I emphasize that the ligand ATRA cannot modulate CRABP's function because CRABP is a binding protein. This slide shows the molecular design, and this compound is ubiquitin ligase ligand. Based on previous information, tethering this moiety would keep the binding affinity toward ubiquitin ligase and CRABP. Next, linker length would affect ubiquitination efficacy. So we designed and synthesized 3 compounds named 4A to 4C, possessing different linker lengths. Living cells were treated with compounds 4, then the level of CRABP1 and CRABP2 were detected by means of Western blot analysis. As a result, compound 4 decreased both CRABP1 and 2. Interestingly, the linker length affected the selectivity. As I mentioned, CRABP2 is associated with the migration of cancer cells. We next investigated anti-cancer activity of hybrid compound 4B. As a result, 4B inhibited migration of cancer cells in dose-dependent manner. From this result, we showed the small molecule CRABP degrader induced anti-cancer cells. Next, we applied targeted protein degradation to neurodegenerative disorders. Neurodegenerative disorders, including Alzheimer's disease, have many symptom and disease-related proteins. However, there is a common pathogenesis of neurodegenerative disorders, that is aggregation of disease-related proteins. We focused on Huntington's disease. We expected that hybrid molecule consisting of ubiquitin ligand and aggregate binder like curcumin would induce ubiquitination and degradation of aggregate proteins. And I'm sorry, in this time, we didn't utilize food active ingredients, but we utilized synthetic dyes for protein aggregates. Then we designed and synthesized 15A and 15B. We treated compounds 15 to the fibroblasts derived from Huntington disease patient, 2 kinds of fibroblasts. As a result, 15A and 15B decrease Huntington disease proteins named MHTT. Now, we are trying to apply this target protein degradation methodology to target identification of vitamin A. the hybrid molecule consisting of victim ligase ligand and HLA was treated to living cells, and level of whole proteins were analyzed by LC-MS, I mean proteome analysis. I hope that decrease the protein molecular target of vitamin A, because this method is unneeded isolation of protein, target protein. We expect little effects on dissociation and stability issue of affinity chromatography. Horizontal axis shows fold change of each protein levels, and vertical axis shows logarithm of p-value. Protein in blue zone, CRABP2 and protein X were significantly decreased by vitamin A victim ligase ligand conjugated molecule 4B. Now we are validating whether HLA bind to protein X. Finally, I thank all lab members, especially Assistant Professor Dr. Tomoshige and Dr. Sato. Thank you for your attention.
Thank you very much, Professor Ishikawa, for very informative presentation. Thank you very much. The floor is now open for discussion. Are there any questions or comments from the audience? Are there any questions or comments?
You have a comment on the chat.
Yes, please. Professor Takahashi?
So you can see the question in the chat. You can see.
Ah, I see. The question is the metabolism of adaptation to equal higher in East Asian population related to conversion with local agriculture.
Sorry, I can't hear you. Please refrain.
May I ask you another question? In your presentation, Mediterranean Mediterranean diet is good for preventing Alzheimer's disease. Should Asian people, such as Japanese, Chinese, Korean, and Indonesian people, change our diet?
Okay. Sorry for. Yeah, there are Japanese version of WHO guideline, and Japanese WHO guideline mentions that it's difficult to modulate our food culture, Japanese food culture. So instead, WHO Japanese guideline recommended balanced, healthy diet, balanced, healthy Japanese diet.
Yes, thank you very much.
And sorry, I can access the chart and the metabolism of Daisen. I'm not sure the reason. Yeah, I will answer the chat against the chart. The question is why Asian people can convert the Daisen to equal. But I'm not sure the reason why Asian people has enterobacteria of which can convert to equal. But it is said that local food may be affected to the environment of microbiome. That's all.
Okay. Thank you very much. So let's move on to the next presentation. Thank you very much, Professor Ishikawa.
Thank you.
The next presenter is Professor Yasue Tanaka from Tohoku University Graduate School of Dentistry. The title of the presentation is Measuring Oral Function in Older Adults. Challenges for matching oral function and food texture. Could you start your presentation?
Yes, can you see my slide?
Yes, please.
Okay.
Yes, I can.
Thank you, Dr. Kanetaka. Hello, everyone. My name is Yasue Tanaka. I'm Assistant Professor of Division of Aging and Geriatric Dentistry, Tohoku University Graduate School of Dentistry. It's a great honor to be given this opportunity to have presentation here in the National Symposium for Interface Oral Health Science 2022. Today, I'm going to talk about new challenges in geriatric dentistry. In this presentation, I talk about the relationship between oral function and frailty. Then I talk about oral hyperfunction and oral sensory function, especially about texture perception. Frailty is considered to be highly prevalent with increasing age and to confer high risk for adverse health outcomes, including mortality, falls, and hospitalization. This figure is known as the cycle of frailty. Markers of frailty include sarcopenia, declining strength, declining working performance, undernutrition, and so on. These factors are theoretically unified into the cycle of frailty. Although decline of oral function is not included in this cycle, but it could modify this cycle by affecting chronic undernutrition. During eating, the structure in oral cavities have multiple functions. When eating solid food, the food is first broken into chewable sites by anterior teeth, then transported to the occlusal surface or posterior teeth by tongue. During mastication, the food is comminuted into swallowable particles and mixed with saliva. Finally, swallowable bolus is transported to oropharynx by the function of tongue and palate. As we age, all or a part of these functions decline or their control is disrupted, resulting in problems with eating. This graph shows the percentage of people having oral health problems in each age group. Oral health problem includes in this study a problem of teeth, gums, eating, and so on. The problems directly related to eating, such as difficulty chewing and difficulty swallowing, are clearly increased with age. As a problem with increased with age are taste loss and dry mouth. Previous studies have shown the relationship between decline in oral function and incidence of physical frailty or other adverse health outcomes. For example, Tanaka and his colleagues showed that poor oral status predicted future physical weakening. In this study, they used 6 items such as the number of teeth and chewing ability to evaluate oral frailty. If the person who had 3 or more poor oral statuses, they were classified as oral frailty. The results showed having oral frailty at baseline significantly associated with more than 2-fold increased risk of physical frailty, sarcopenia, disability, and mortality. Additionally, the Cox proportional hazard model revealed that participants with oral frailty were at significantly increased risk of experiencing all those outcomes. In order to prevent adverse health outcomes, such as frailty and sarcopenia at an early stage, it is important to evaluate oral function. In 2016, the Japanese Society of Gerodontology, or JSG, published the position paper about oral hyperfunction. In this paper, JSG focused on oral function and created a conceptual diagram divided in 4 stages. This diagram illustrates that the stage of oral frailty and oral hyperfunction can be restored to the previous stage by various remedies described in each level. Oral hyperfunction is defined as the stage at which recovery can be expected by performing dental treatment before oral dysfunction occurs. JSG selected 7 conditions for making a diagnosis of oral hyperfunction and established initial thresholds to be used as diagnostic criteria for these conditions. To evaluate oral hygiene, each tongue surface was divided into 9 sections, and the degree of tongue coating is assessed by visual inspection. Tongue coating index 50% or higher is considered as poor oral hygiene. The oral moisture checker is used to measure mucosal wetness of tongue dorsum. The measured value less than 27, or the result of suction test smaller than 2 grams per 2 minutes, is considered to be oral dryness. Occlusal force is measured by pressure indicating shears. When the occlusal force is less than 500 Newton with dental stress scale 2, or the number of natural teeth is less than 20, the occlusal force is considered to be reduced. Comprehensive measurement of motor speed and dexterity of the tongue and lips are taken as oral diaptocokinesis. Participants are instructed to produce each of the syllables pa, ta, and ka repeatedly for 5 seconds. When the number of any counts produced per second is less than 6, tongue with motor function is considered to be decreased. In order to measure tongue pressure, the participant is instructed to compress a balloon attached to the tongue pressure probe onto the anterior palate for a few seconds. The maximum tongue pressure less than 30 kilopascal is considered to be decreased tongue pressure. Then, gummy jelly is used to evaluate muscular function. Glucose concentration obtained from chewed gummy jelly less than 100 milligrams per deciliter, or the fracture score 2 or less by comparing with the visual reference materials are considered to be decreased muscular function. Finally, deterioration of swallowing function is assessed by IOHS10. The total score 3 or higher means deterioration of swallowing function. JSG defined oral hyperfunction as the state when 3 or more of these diagnostic criteria are met. Although each symptom does not indicate a disease, the accumulation of these conditions can lead to frailty or the state of requiring long-term care. Thus, diagnosis of oral hyperfunction at an early stage is important to prevent the progression of frailty. Currently, these criteria are used for both clinical and research purposes. The recent article by Nishi employed the same criteria with JSG to evaluate oral hyperfunction. Oral hyperfunction was significantly and independently associated with protein intake in both men and women. Similarly, protein intake was associated with the number of poor function indicators in oral hyperfunction. Regarding each oral function, none of them was significantly associated with protein intake. The importance of comprehensive assessment of oral function was supported by this study. Until now, several articles which use JSG criteria to evaluate oral hyperfunction have been published. These studies showed that as much as 60% of community-dwelling older adults had oral hyperfunction. The role of dentistry is changing as the number of older people with impaired eating function increases. Dental treatment for recovering morphology might not be enough to achieve adequate nutrition. In that case, dentists need to prescribe exercise for patients to recover oral function. Moreover, when the exercise is not sufficient to restore the oral function, the dentist should prescribe food with appropriate physical property. However, we don't yet know how to select the food with appropriate physical properties for each patient with oral hyperfunction. There are several classifications of texture-modified foods, both domestically and internationally. Generally, these classifications are made on the basis of the physical properties of the food, such as hardness, adhesiveness, and cohesiveness. However, the correspondence between the classification of texture-modified foods and oral function is not understood. Hence, it is still difficult to choose the foods with appropriate texture, even though the results of oral hyperfunction tests are available. There are several other methods to evaluate oral function during eating. The methods used for JSG criteria are good enough to diagnose oral hyperfunction. In order to match oral function with appropriate food property, additional examinations such as listed here may also be needed. So far, I've talked about oral motor function related to eating. Now, I'd like to look at oral sensory function, which is also very important during eating. Decline in sensory function could inhibit one's appetite and could eventually cause undernutrition. As I have already explained, oral motor function can modify the cycle of variety by affecting chronic undernutrition. On the other hand, decline in oral sensory function can modify the cycle by affecting the appetite. Therefore, evaluating oral sensory function is also important. The relationship between the taste difficulty and malnutrition was shown in hospital older patients. This study shows having taste difficulty is associated with a significantly higher prevalence of malnutrition, and the odds ratio was 2.96. So this study suggesting decline in oral sensory function caused malnutrition. Of those oral sensory function, we are especially interested in oral texture perception. ISO defines texture as all the mechanical, geometrical, and surface attributes of a product perceptible by means of mechanical, tactile, and where appropriate, visual and auditory receptors. Food texture is represented by various terms such as hard, soft, crispy, juicy, and so on. We think that the texture perception is critical for older adults because texture perception can be related to the safety swallowing. The texture of food continually changes while mastication takes place. It is believed that there are specific textures that are suitable for swallowing. Hutchings and Dilford schematically represented the trajectory of food during oral processing. This three-dimensional model is postulated with degree of structure, degree of lubrication, and time as its axis. Before swallowing can take place, the degree of structure must have been reduced below a certain level, and the degree of lubrication must be above a certain level. On the other hand, numerical model by Prince and Lucas shows that there was an optimal moment to swallow, defined in terms of a P-cohesive force between food particles. Texture perception is important to detect appropriate texture for swallowing. Texture perception is also important because it is related to palatability. Decline in texture perception may influence food choice and cause undernutrition. Despite the important role of oral texture perception, any clinical protocols were not available to evaluate its acuity. we developed the method to evaluate the acuity of texture perception by using various concentration of agar-gel, xanthan solution, and microstat in cellulose suspension. Currently, we are investigating the relationship between the acuity of texture perception and the kind of oral functions such as tongue pressures. In summary, accumulation of poor oral conditions may lead to clarity in older people. Thus, early diagnosis of intervention in oral hyperfunction is crucial. Selection of appropriate foods requires assessment of multiple oral functions, and the methods to evaluate oral function should not be limited to the methods used for GSG criteria. Among the older people who lack appetite, some may have reduced oral sensory function. The evaluation of sensory function is equally as important as evaluation of motor functions for older people with eating difficulty. Thank you so much for your kind attention.
Thank you very much, Professor Tanaka, for excellent presentation. Now the floor is now open for discussion. We will expect questions or comments from the audience. Are there any comments or questions? May I ask you a question?
Please.
どうぞ、高橋先生。では私からいきます。May I ask you a question? Yes. I have a question about how to test for hypothyroidism. You mentioned that additional tests such as VF, swallowing, endoscopy, or EMG are needed. How can these additional tests help you choose the diet?
Thank you for the question, Dr. Kanetaka. Because the oral function during eating is very complicated and the movement is very important, but all criteria for produced by JSC is based on static, it's just a value. So we cannot understand the movement, but if you can use video fluoroscopy and endoscopy through the sonography and electromyography, those are able to measure the movements of, and also we can measure the movement of food directly or indirectly by those methods.
Thank you very much. May I ask you one more question?
Yeah.
You also talked about developing a new methods for inspecting texture sensations, right?
Yeah, correct.
Could you please explain the new methods in more detail?
Okay, so our method is to measure the acuity threshold of detection, threshold of the detective threshold between two different concentration of the same ingredients. So the subject has to give correct answer whether which of the two items is have more xanthan gum or more microcrystalline cellulose. So we can detect how they can detect the thickness by using thickness and springiness of, sorry, I cannot explain very well. So the acuity of texture perception is available by this test. And if we can understand the texture perception, the acuity of texture perception, maybe some patients who have decline in who complain about taste, who complain taste disorders. Some may have picture perception problem. So for those patients, we should prescribe picture enhanced food or something like that.
I understand. Thank you very much. Any questions? Professor Takahashi?
You have a question on the chat.
Okay.
Yes, I can answer this question. So the question is about which entity issues the diagnostic criteria for oral hyperfunction. This is from the Japanese Society of Japanese Society of Gerodontology. So Japanese Society of Geriatric Dentistry. So, and this is also covered with Japanese national insurance. So this method is very accepted in Japan.
Okay. Thank you very much. Are there any other questions?
Okay. So may I have one question?
Yes, please.
Thank you very much for your comprehensive presentation. I learned a lot about oral hypofunction or something like that. And also you mentioned the importance of the evaluation of oral motor function and oral sensory function, right? So my question is that maybe we need a kind of standard food to evaluate these factors. So such kind of the standard food is available?
No, I don't think so. So we need to collaborate with food developer at other area of researchers. So it's always very difficult to select standard food and to modify the texture of the food.
I see. So now I recognize that producing the kind of standard food is also the important task of Shokugaku science.
Yeah.
Yeah. Thank you.
Thank you.
Thank you very much. Are there any other questions from the audience? If there are no more questions, now it's time to close the session. Thank you very much, Professor Tanaka.
Thank you.
Thank you.
Thank you very much.
I'm happy to say we have managed to finish these fruitful sessions successfully on schedule. Thank you very much for all the audience and all the presenters. Thank you.
Thank you very much. So now we will move to Keynote Session 3. The theme of this session is Big Data Analysis in Health and Social Science. The chairperson of this session is Professor Ken Osaka from Tohoku University. Thank you for your time.
Okay, ladies and gentlemen, and thank you very much for participating this session. So this is the last one for today, and data health. But today we have great speakers from 3 countries, and which covered big data science, and social science, and health system. And fortunately, all of the speakers already recorded their presentation, and all speakers here, but so we have to listen at the recorded presentation first. Okay, first speaker is Dr. Pachan-chat. So title is Social Cultural Context and Oral Health in Thailand. So 事務局の方は、please start the presentation.
Good afternoon, Dr. Chairman, President of IOHS, Deans of Faculty of Dentistry, and everybody here. My name is Dr. Piyachat Pacharanuchat from Faculty of Dentistry, Khon Kaen University, Thailand. It's my honor to join this international symposium and have a good chance to share experience with you. My topic in this session is socio-cultural context and oral health in Thailand. Socio-cultural context affect oral health in Thailand in many ways. It's similar to every society. A complex phenomenon of oral health appears as an ultimate outcome from web of interrelation of particular social and cultural elements. It was found that they influence in people's circumstance and condition of living, which were dynamic, changeable, and vary from society to society. Everybody may be familiar with this figure of host, aging, environment in public health. For oral disease, we know that the host elements are tooth structure, saliva, oral cavity, and human body. Let's see the people attitude, thoughts, belief, and people roles are still the host element as well. Similar to the elements of environment, we know about the bacterial plaque, fluoride, foods, and drinks. And in this presentation, I will take you to focus on this frame: socio-cultural context, social norm and belief, and health service system. After an adoption of social science and medical anthropology in dentistry in Thailand, oral health phenomena in Thailand were clarified for dental professionals. The source of data came from qualitative research, health promotion projects, and case studies that my colleagues, and my students provide and participate in Thailand for many years. Let's see this first one. Thailand was a sweet tooth society. This graph shows an increasing of sugar consumption in Thailand from 1983 to 1998, from 12 kilograms per person to 28 kilograms per person a year. It grows up in the same direction of the growth of agriculture industry, following the National Economic and Social Development Plan. Sugar consumption in 2001 was 29 kilograms per year per person. Even in 2015, it was still high in 30.5. Actually, it was 3 times overconsumption that World Health Organization recommend. We all now realize about the health impact from sugar overconsumption. Well, how we deal with this problem? "20 years before, there was the health advocacy to promote sweet enough society in Thailand. The network of health scholars such as physicians, nutritionists, health policy makers, customer activists, and dentists work together under the supporting of Thai Health Promotion Foundation. So many of strategy and health projects were launched to create new norms as sweet enough through the reduced sugar consumption campaigns. You can see the cartoon of the pink ant, the mascot, to educate children about sweet enough eating. And let's see the poster, aim to beware lifestyle of fatty kids, to promote healthy food choice and to remind sweet enough eating. By the message of body image and health reason, especially non-communicable disease, at the present time, sugar-free low sugar, unsweetened drink and products were more available in convenience store shelves in Thailand. In addition, in 2016, sugar tax policy was passed in Thailand's government and forced in control over sugar-sweetened beverage. Is one in very important health policy in Thailand. The news report of Bangkok Post said on July 2019, the beverage industry is experimenting with and rolling out healthier drinks ahead of new levy. The new levy is, for example, nearly 30% of selling price of drinks of added sugar over 18 grams per 100 milliliters. However, commercial advertising of sweets was still problematic in school because it depends on school policy and could control only inside school but not for outside. Let's have a look on the second oral health phenomenon. I will present about doctor-patient relationship in Thailand. There were feelings of faith and confidence, obedience and respect for doctor, dentists, and other health professionals among Thai people. Perceived image of health personnel was knowledgeable, helpful, and merciful. As a result, in power imbalance in doctor-patient relationship. For example, from the project of Laser in Dentistry Research Group, Khon Kaen University, we found that to propose laser dentistry in one community was not difficult to convince people to accept an innovative treatment. Patients expressed trust, faith, and belief in doctors. On the other hand, it was a pressure among School of Health Science to design lessons of sympathy for patients. In Khon Kaen University, Thailand, COMMET KKU is the subject of integrated health science fieldwork. By using method of medical anthropology, students need to stay overnight in the villager's house for a week. The purpose was for students to understand the ways of living of vulnerable people in rural areas. We found that sympathy makes students more humble and respectful to those being suffered. Well, this project was conducted for 39 years. It was impacted by the pandemic of COVID-19 as well. The project continued, but we need to adjust activity and we still keep objective of the subject. The third one, I will discuss about social norms that influence in oral health in Thailand, especially social norm of beauty and cleanliness that affect perfect smile by the time. For 400 years before, black color teeth was fashionable and meaningful among upper-class Thai women. It was still found butternut-stained teeth among aging people in rural community in Thailand. But it's not much and not for a reason for beauty. But nowadays, while white and bright mean cleanliness for Thai people, the black colored teeth of children from silver diamond fluoride were unacceptable among Thai peoples. I found this as a case study with my student in dental school program, Khon Kaen University. Moreover, teenagers' teeth with braces were more popular even though no treatment need, and this often end up with dispute in dental clinic. An illegal dental service was still exist to encounter professional law. In 2008, commercial ads for fashionable braces was over 20,000 Thai web page by Google search engine. Other phenomenon, the fourth one, was some of people believe need to be concerned. In the macro level, for example, sweet food was common among Thai children, so was deciduous tooth decay. That's why we do not think was a reason of just people. This slide shows the finding from my undergraduate student study for Thai Isan Way, or lifestyle of the people who live in northeast part of Thailand. Parents need to leave their little children with grandparents to work far away from home in the big city for the reason of economic suffering. So what happened? The grandparents, especially grandmother, need to look after their little kids by lack of knowledge and skill. This includes lack of knowledge and skill of the oral health care. And most of the grandparents will more often have health problems, and some of them limit of movement. So they face the problem to look after the child or the child management. Finally, to the reason to give the sweet snack for the children was they think that it compensates love and missing to mom and dad who work far away. In micro level, I found the oral health phenomenon in a rural village. It was widely believed that tooth extraction could affect brain and nervous system as prosthesia in Thai words. It resulted in avoiding to receive dental service in hospital. A case study was from my research 30 years before. Children in one family did not allow to have tooth extraction because of the belief of their grandparents. However, this belief still exists at the present in northeast part of Thailand and have been confirmed in the seminar class of my postgraduate student. Application and understanding of socio-cultural context could fulfill activities in oral health promotion and prevention. And evidence of Muslim society in south part of Thailand display religious faith through personal hygiene and cleanliness before prayer, focusing on toothbrushing. Muslim religious leaders participate in oral health advocacy by leading men who were heads of family to concern on oral cleanliness to communicate for God. Also, the leader indicate an importance of teeth in oral cavity to precise pronunciation during prayer and devotion. After that, this practice came into their house and children. This oral health promotion project in Pattani province won the first prize of Lion Oral Health Award in Thailand in 2017. The other evidence in rural area of northeast part of Thailand, the action research from my student display capacity of village health volunteer and community participation to empower child carers by set up community rules as healthy public policy to inhibit toddlers' meal bottle at bedtime. It could be noticed that the social support by this community could lead to healthier behavior even in individual level. The remarkable application for health promotion in Thai society was to create new social norms as alcohol treating equal in giving curse and stop drinking alcohol during Buddhist Lent. These two health promotion campaigns supported by Thai Health Promotion Foundation. You can see this picture. For seasonal greeting, Thai people had ever used alcohol for the present. To stop this norm, the health promoter used the word of curse. Also, for another stop drinking campaign, health promoter come along with the religious duration time of 3 months Buddhist Lent and asked the famous monk Tanwa Vajrameti to participate in this campaign. This stratagem convinced Thai people to new practice by tying with Thai socio-cultural context. Finally, a complicated health behavior of individual was a result from how people live in a particular society. Therefore, creating healthy behavior and supporting health environment in a society could be achieved by an understanding of socio-cultural context as a whole in each society. As the current circumstance of the socio-cultural context and oral health that I mentioned before, for the future direction of research, I recommend you to combine soft science, biomedical anthropology, and social science in oral health research to clarify health-related human behaviors in different perspectives. In particular, you could call experts in multidisciplinary outside dentistry as a research team, and then enjoy learning and researching the research. For acknowledgement, I would like to thank you, President of IOHS 2020, Dr. Nobuhiro Takahashi, and Chair of Organizing Committee, Dr. Kwon Hong. And I would like to thank you, Dean of Faculty of Dentistry, Khon Kaen University, Associate Professor Dr. Waranut Pitipat, for academic support. Thank you for your attention.
Okay, thank you very much for that presentation. I'm very impressed and your activity and from grassroots level. And sometimes in many countries, some paternalistic approach, government decides something like that. So this is great activities and also research. Thank you. So this time is open for the question and comment and from other audience. Is there any question or comments? And I'm very much feel very happy to hear that Thai government maybe sometimes it just causes a conflict between healthy industry and sugar industry. And but your government, your country installed maybe sugar tax, and maybe in collaboration with other health professionals. I believe envy you. And one question is from the audience. Can you elaborate more about the 2016 sugar taxation? So how was the result of the sugar taxation? And maybe you did maybe show the results, some of the results in your slides. Okay.
Okay, thank you for the question. Actually, for this strategy for the sugar tax in Thailand, we can claim that it might be the first one in the Asia to try to launch it. Actually, I need to mention two scholars, both are my colleagues in the health promotion project, Dr. Chantana Eungchusak and Dr. Piyada Prasasom, who ever works in the Bureau of the Dental Health in the public Ministry of Public Health, because they work together with numbers of people in different ministry and try to launch this sugar tax. And actually from the 2016, after it's passed in the Thailand Parliament, it's like the 5 years duration of time for the beverage industry to adapt and try to find out how to create the new beverage, something like that. And now we can notice the numbers of the beverage and some sweet sugar product in convenience store as well. And no, moreover, the beverage industry use this point as the commercial as well. I think it's like the win-win situation for now.
Okay, further, maybe how much percent increase was it? How was people uptake for the policy? Was it nationwide? Maybe is there any conflict of some people's perceived maybe acceptance of this? Maybe people have to pay more tax for purchasing some beverages, sweetened beverages. So, what is the feeling of the people's perception for the introducing this sugar tax?
I'm not sure because we have not much the data for that, and actually maybe the further study if this satisfaction or not for the people, but I'm quite sure for one, people have the more concern on the health reason a lot. This is quite clear in Thailand.
And also, this is just focuses not only some sugar reduction, but also some alcohol reduction, and maybe some combined with some tobacco initiative or others. So, do you have some collaboration with other campaign or?
Yes. Yes. Not only the sugar tax, but we need to have the another health promotion campaign as well. As I mentioned in the presentation about the pink ant promotion of Sweet Enough Thailand. Actually, our work in Thailand, we try to launch the numbers of the health promotion project to educate people about now we have the too much sugar consumption, something like that. And we need to send the message, the message of the sugar sweet enough, not refuse the sugar, but sweet enough consumption.
Okay, another question from the President Nobuhiro Takahashi. Nobuhiro 先生、どうぞ直接。Please video, turn on your video and directly ask for her. Oh, I just another question is sugar tax is wonderful. My question is about what types of sugars are targeted. I might miss your presentation. Maybe you did show that there's some concentration of the sugar and of the tax, but there's many sugary maybe food, beverage and cake and cookies and many things.
Yeah, or even the sweet milk in school. Yeah, we need to promote and give more information to the people. And other project, for example, the ministerial regulation and law to stop using the sugar ingredient in the follow-on milk formula for the children in the 6 months to 2 years. That's the regulation in Thailand for now. So have no any product like that in Thailand.
For sugar taxation is covered not only the sweetened beverage, but also other maybe cookies and cakes and but in Japanese food, there a lot of sugar was added in Japanese traditional one. So how to regulate some maybe tax food?
We still have no any policy, healthy public policy for that kind of food, especially. But just the health promotion program combined in the in school, in some workplace, and we just give the message of the sweet enough. When you eat, we need to concern on the sugar over consumption for that. And we start with the sweet beverage because for 20 years, from 70 years before in Thai people, we love to have the coffee and sweet drink so much. So yeah, most of us think that we need to start from that.
Okay, thank you very much. Any other question? And maybe it's very wonderful things for Thailand install that is the sugar tax, and maybe so please extend to other Asian countries. So many Asian countries is suffering from the lot of sugar beverages, sugar industry, their tax strategies. So maybe in collaboration with the experience, we have to learn a lot from Thailand and maybe install the new campaign in other countries also. Thank you very much.
You're welcome. Thank you so much.
Well, thank you very much. So we will move to next speaker, Dr. Kenji Takeuchi. His title is Results of Cohort Studies of Highly Generalizable Population and Nationwide Big Data Studies, and the future of epidemiological research using real-world data. So please start Kenji's presentation.
Thank you very much for giving me this excellent opportunity. I'm Kenji Takeuchi and a researcher on oral epidemiology from Tokyo University. Today's presentation title is the result of cohort studies of a highly generalizable population and nationwide big data studies and the future of epidemiological research using real-world data. Here you can see today's presentation outline. There are three things I'd like to cover today. Here, let's start with an explanation of the importance of the generalizability of the study population. This slide shows the two main purposes of epidemiological studies. It is widely recognized, not only by researchers but also by clinicians, that the main purpose of epidemiological studies is to investigate the causes of diseases. In clinical practice, the results of epidemiological studies are often used to evaluate which is more effective among various treatments in various situations. On the other hand, another important purpose of epidemiology is to provide basic information for the development of policies that contribute to improving the population health, such as disease prevention and control. From a public health perspective, the generalizability of the study population is important. In order to apply the results of epidemiological studies to practice and contribute to disease prevention and health promotion at the population level. So, what is generalizability? Very simply, generalizability is a measure of how useful the results from the study sample are for a target population. If the results of a study are broadly applicable to many different types of people or situations, the study is said to have good generalizability. If the results can only be applied to a very narrow population or in a very specific situation, the results have poor generalizability. On this occasion, I'd like to take up a cohort study specialized in the generalizability and introduce study results focusing on the association between oral health and general health in the general adult population of Japanese. Next, I'll introduce the result of the Hisayama study, which is a cohort study of a highly generalizable population. First of all, I would like to give a brief explanation about the town of Hisayama, which is the origin of the name of the Hisayama study. Hisayama town is a small town located near Fukuoka City in the Kyushu region of Japan. Geographical situation of Hisayama town is suitable for dormitory town. However, the municipal government of Hisayama town did not want to change natural environment of the town and have restricted urbanization by inhibition of combating farmland to homesite. Therefore, population of Hisayama town in 2012 increased only 1.2-fold compared to that in 1960, whereas population in Fukuoka City increased 2.3-fold during the same period. That is, population movement in Hisayama town is relatively steady state. As a result, as shown in the population pyramid here, over the past 50 years, the residents of Hisayama town have shown almost the same age distribution as the national average in all age groups. In other words, you can see that the residents of Hisayama town were and still are an average Japanese people with almost no bias. I had participated in the Hisayama cohort study when I was affiliated with Kyushu University. The Hisayama study was started in 1961 for the purpose of clarification of etiology of cerebrovascular disease in Japanese by medical school in Kyushu University. The large health examination of all adults over the age of 40 living in Hisayama town has been carried out every 5 years. From 1998, my previous laboratory joined this study, but dental examination is time-consuming and we can evaluate only 1,000 subjects at 1998 survey. Therefore, it was only after 2007 that we were able to start large-scale dental examination in earnest. Since then, we have participated in every large-scale health examination every 5 years in 2012 and 2017. Some of the results of the Hisayama study examine the relationship between oral health and general health, in particular non-communicable diseases, and here I'll introduce the relationship between the number of teeth and the risk of developing dementia, as published in Journal of American Geriatric Society. The study subject was 1,600 adults ages 60 years and older who underwent a large-scale health examination in 2007 and were followed up for about 5 years. For tooth loss, the number of remaining teeth was measured from the oral examination and classified into 4 groups. The onset of dementia was diagnosed by a psychiatrist using the DSM-3R, a diagnostic manual for mental disorders. This graph shows the result of a multivariate analysis of the relationship between the number of remaining teeth and all-cause dementia, after adjusting for gender, age, lifestyle, and socioeconomic status. The adjusted hazard ratios were 1.6 times for 10 to 19 teeth, 1.8 times for 1 to 9 teeth, and 1.6 times for 0 tooth compared to 20 or more teeth. This indicates that the risk of developing dementia increased as the number of tooth loss increased. The p-value for trend was also found to be significant. Next, when looking at dementia by disease type, the crude hazard ratios for both Alzheimer's disease and vascular dementia showed a significant increase in the risk of developing dementia in the following stages: 10 to 19 teeth, 1 to 9 teeth, and 0 tooth, compared to 20 or more teeth. After the adjustment for covariate in the multivariate analysis, there was no significant differences in each category for Alzheimer's disease, but the trend was almost the same as for all dementias. In contrast, vascular dementia showed no trend toward an increased risk of developing the disease as the number of teeth decreased, although there was a significant category. In sum, This study demonstrated that tooth loss is a risk factor for development of all-cause dementia and Alzheimer's disease in an older Japanese population. The findings emphasize the clinical importance of promoting and supporting opportunities for dental care and treatment from an early age for reducing the risk of dementia in later life. Here, I'll introduce the relationship between periodontitis and the risk of developing chronic obstructive pulmonary disease (COPD), as published in Journal of Dental Research. The study population consisted of 1,600 adults aged 60 years and older who underwent a large-scale health examination in 2012 and were followed up for approximately 5 years. The severity of periodontal disease was classified into 3 groups: no or mild periodontitis, moderate periodontitis, and severe periodontitis. This classification was according to the classification by the Centers for Disease Control and the American Academy of Periodontology. For the diagnosis of COPD, we followed the gold classification system and the method recommended by the American Thoracic Society and the European Respiratory Society. This graph shows the result of multivariate analysis of the relationship between the severity of periodontitis and the development of COPD, after adjusting for sex, age, occupation, diabetes, and so on. The adjusted risk ratios were 1.5 times higher for moderate periodontitis and 3.5 times higher for severe periodontitis compared to no or mild periodontitis. The P4 trend was also found to be significant, indicating that the risk of developing COPD increases with the severity of periodontitis. In addition, we examined the combined effect of severity of periodontitis and the intensity of smoking on the development of COPD. Compared with non-smokers with non-severe periodontitis, non-smokers and moderate smokers and heavy smokers with severe periodontitis had 3.2-fold, 4.3-fold, and 13.8-fold higher risks of developing COPD, respectively. This result means that the risk of COPD in subjects with severe periodontitis was increased in accordance with the intensity of smoking. In other words, the results indicated that it is important to combine measures against periodontitis with measures against smoking to prevent the onset of COPD. Next, I'll talk about the importance of the big data analysis. The term big data, which refers to the rapid integration and analysis of large amounts of information, has become widely used. We have explained the importance of big data from 2 aspects, high volume and high variety. First, high volume refers to data with orders of magnitude more observations and orders of magnitude more variables per observation than prior dataset in the domain. An example of this would be a National Electric Health Record database. Next, high variety. This refers to the practice of incorporating data collected originally for disparate purposes into a single dataset for combined analysis, such as combining data from electronic medical records with purchase histories or social media profile updates. In sum, big data hold promise to identify population health intervention targets through analysis of high volume and high variety datasets. Next, I'll introduce the result of the Japan Gerontological Evaluation Study JAGES project. The JAGES project is a large-scale study of more than 200,000 older people throughout Japan. The aim of this big data project is to create a scientific basis for preventive policies aimed at creating a healthy and long-lived society, focusing on social determinants of health and well-being. The figure here shows the participating municipalities, which come from all over Japan. Various universities are participating in this project, including Tohoku University, Tokyo University, Chiba University, and Harvard University, and so on. I myself have been involved in these projects since I participated in the JAG's 2010 survey. This figure shows the result of JAG's big data study of about 80,000 older adults. And this indicates the association between number of remaining teeth and survival time with and without disability. Both men and women, those with larger number of remaining teeth, had longer survival time without any disability. The findings mean that having more remaining teeth was independently associated with lower risks of mortality and functional disability and a shorter life expectancy with disability in a population of older people in Japan. Next, I'll introduce the results of the Japan Coronavirus Disease 2019 and Society Internet Survey JLCSIS-JAXIS. It is believed that big data can be used to make optimal public health decisions faster and improve the negative impact of public health incidents such as COVID-19. In terms of addressing the major public health problem of COVID-19, this figure summarizes the big data sources that can be used to support and implement pandemic prevention and control. For example, the development of social media platforms provide a new stream of big data to carry out disease prevention and control. Now, as part of this, I would like to introduce our study that assessed the impact of COVID-19 outbreaks on oral health using Internet survey data. This study is based on the result of 25,000 respondents to the JAXIS, a large-scale Internet survey in Japan, as published in Journal of Dental Research. As a result, dental pain was observed in 9.8% of the respondents. This figure shows the result of multivariate logistic regression analysis. Those who experienced a decrease in household income, work reduction, or job loss due to the COVID-19 had 1.42, 1.58, and 2.17 times more dental pain, respectively. These results indicate that dental pain is more common in people whose socioeconomic status has been worsened by the COVID-19 pandemic. Lastly, I'll talk about the future development of epidemiological studies using real-world data. Real-world data and big data are not synonymous, but the two terms seem to be used with little distinction in epidemiological studies. Big data, especially patient data, routinely collected by electronic means, is called real-world data, and this is becoming more common in medical research. In addition to the characteristic of big data, real-world data has the following important additional feature. Its high velocity. High velocity refers to the data generation process that collect and analyze data in real time or nearly real time through algorithms without human intervention. Also, a feature of real-world data is the potential to design dynamic interventions, such as medication adherence interventions, tailored to the subject response patterns. Although randomized clinical trials are considered as a standard for obtaining evidence. The use of real-world evidence is attracting attention to evaluate the efficacy and safety of medical treatment. Tohoku Medical Megabank Organization, TOMMO. This project conducted a long-term health study of residents living in the Tohoku area and has been in developing a biobank that combines medical and genome information. We aim to establish a database on the oral health of the residents living in the Tohoku area, and also aim to gather evidence of the links between oral health and general health through examination of the population's lifestyle and genetic predisposition. We have already surveyed over 30,000 people on the items listed in the table below. For example, we assessed dental caries, tooth loss, restorative treatment, periodontitis, oral mucosa condition, signs of TMJ disorder, oral care habits, and oral health-related quality of life. In addition, we collected dental plaque, tongue coating, and saliva samples. Furthermore, a variety of other biospecimens can be provided upon application. In the near future, we plan to disseminate evidence of the effectiveness of dental treatment and checkups in the real world by combining health information and biological specimens with patient records as real-time data. This is because even research topics that are difficult to examine in RCTs can be examined as observational studies with real-world data. So, in conclusion, oral diseases are one of the most prevalent diseases, and thus, oral health is important because it affects general health. And another important message is this: it is important to use big data or real-world data to evaluate the effectiveness of dental treatment, health checkups, and other interventions. Thank you for your kind attention. That's all.
Okay, thank you very much, Professor Kenji Takeuchi, and a great presentation and discovering and some a famous cohort study and focus on some COPD and dementia and other diseases. And you also comprehensively explaining the big data study and some real-world study using another cohort, JH and TOMO. So very interesting story, but any question or comment, welcome. Okay, you explained many studies on using cohort study or real-world data. So any your future plan using this TOMO or real-world data data set?
Oh, thank you, Professor Osaka, and thank you for asking about that. I hope to use real-world data in the future to examine whether appropriate oral health care can delay the onset of nursing home care needs and reduce the burden or cost of nursing care. And also, it would be interesting to examine whether there are differences in these relationships across multiple countries. This is because we believe that the impact of differences in oral healthcare methods and dental insurance systems in different countries will be show up there.
Okay, so he is hoping that some in collaboration with some participants from Asian countries. Okay, it's time to thank you very much for your presentation. We will move to last presentation. So last one is Dr. Toan Kim Hing, National Dental Research Institute of Singapore. The title is Integrating Oral Healthcare Transformation and Health Services Research. Okay, please start your presentation now.
Good afternoon. First, I'd like to thank the Tohoku University for inviting me to share our transformation journey in terms of model of care transformation and also of our population health initiatives. So the outline of my presentation consists of the following subtopics: healthcare challenges, burden of oral diseases, health system transformation, defining value, integrating oral health and general health, and also on building partnership with primary care. Healthcare challenges. Health systems across the world face significant challenges due to aging population, increasing communicable diseases, rising healthcare costs, patient experience, uneven quality, and significant variations in health outcomes. The situation is worsened with the volatility of the COVID-19 pandemic, especially with emerging of new variants like the Delta and Omicron. In Singapore, the proportion of seniors aged 65 will double in 2030. Although we have one of the longest life expectancy of 85 years, the years in ill health has also increased from 9 to 10.6 years. Chronic diseases are on the rise, and healthcare expenditure is expected to increase 3 times in 2030. Burden of oral diseases. Burden of oral diseases and tooth loss. The Global Burden Disease Study 2017 estimated that oral diseases affect 3.5 billion people worldwide. Nasal caries and severe periodontal diseases were a major contributor to the loss of natural teeth. And burden of oral diseases also accounted for a large proportion of disability adjusted life years. Tooth loss has a significant impact on daily, especially in developed countries with high social demographic index, for example, like Singapore. Our statistic of tooth loss in Singapore show that the number of natural teeth and proportion of people with more than 20 teeth increase with increasing age. Only 9.1% of elderly aged 18 and above had at least 20 teeth. 31% are edentulous and no teeth, and 30% did not have dentures. Poor oral health affects oral function, quality of life, and general health of seniors. Hence, oral health is an integral component of general health. Health system transformation. Spurred by a rapidly changing healthcare landscape, many academic health systems across the world are reconfiguring to move beyond individual patient care, that's first curve, towards patient-centric and population care-based care, that's curve number 2. And the third curve of population health improvement, where forging partnerships with community is key. In terms of the financial model, it is moving from a fee-for-service model to a value-based and capitation model. The Singapore healthcare system is divided into 3 regional clusters, and the National Dental Centre of Singapore is situated in the Eastern Cluster, and it is one of the largest clusters, and it's called SingHealth. Within the cluster, we have the general hospitals, the community hospitals, the primary care polyclinics, national specialty centers, specialized hospital, and medical school. We are guided by the Ministry of Health master plan, towards SG Health 2030. The healthcare master plan was introduced in 2012 to enhance accessibility, affordability, and quality of healthcare to meet the needs of Singaporeans. In 2018, the Ministry of Health launched the 3 Beyonds that we can meet our long-term healthcare needs in a sustainable manner. So the 3 Beyonds consist of beyond quality to value, to provide better guidance on cost effectiveness treatment, beyond healthcare to health, to encourage Singapore to lead to healthier lives, beyond hospital to community, to invest in community care and bring social and healthcare services closer to our people. We're also moving on to SG Health 2030, where healthy population is key and also affordable care is a consideration. In our presentation, we'll highlight to you our journey in terms of model of care transformation and also populational transformation that we started on 2018 until now. Beyond quality to value, defining value and measuring outcomes. Why is value important? Value is created in caring for a patient condition over the full cycle of care. It is defined as the outcome that matters to the patient and the cost to achieve those outcomes. It has been used as a tool to reduce significant variation in care and health outcomes. It will benefit patient, providers, payers, suppliers, and population. So the equation to value is quality over cost plus the service, the patient experience plus the appropriateness of care. And the concept of value is espoused by the well-known Professor Michael Porter. The framework that we use is a step 1 to 4 framework. First, we look at the conditions that we want to develop the value-driven care. It could be a single episode, multiple episodes, or a complex episodes. Then we define the quality to measure. It could be the outcome, the cost, the patient-reported outcomes, the appropriateness of the care. And from there, we do the data analysis, the clinical data, operational data, and also we do a data visualization. From then on, then we can compare and we look at how we can improve on the value of the care. In our journey, we have 6 conditions that were identified. These include root canal treatment, dentures, braces, dental implants, third molar surgery, and in 2020, we included the periodontal treatment. In our value-driven care denture pathway, here it illustrates that we have significantly increased the number of appointment visits for the patient from 6 to 4 by combining some of the visits. So this is how we create value for the patient. We have also improved on the referral processes by having a tighter referral criteria and also to have the appropriate complexity that are referred to us. This is done through engagement with our care partners. In doing so, we are also able to improve on the wait times and the total wait times for the patient to receive the denture. In addition to that, we have also tried to improve patient experience by having patient education guide, and this is available in a soft copy and also hard copy. We also introduce financial counseling to explain to the cost to the patient and also the schemes that are available. And the graph on the right side shows that the patient's acceptance to the improved patient experience. We also did a deep dive cost analysis. So here you can see that there's variation in terms of the charges that was levied onto the patient, and also the high variation in patient fees. And this could be a result of inconsistent charging. And we have done that by actually, we have improved on that by having bundled payment to reduce variation and also to reduce the indirect cost to the issue of the denture. To define value and to measure outcome, we have also done a judicious selection of indicators by what we call as a composite index, or it's known as clinical quality index. This is done through engagement with the stakeholders. So the picture on the right shows how the clinical quality index is derived. The indicators that are, in this instance for dentures, there are 7 indicators, and under each indicator, patient must fulfill the criteria. So in this instance, out of the 5 individuals, which are the patients that went through the treatment, only 2 patients that fulfill all the criteria. Therefore, the index score is actually 2 out of 5. It's about 40%. This is the clinical quality index is an all of non-composite index representing the percentage of cases with all indicators that were met. We can also create a CQI dashboard for complete dentures. So the CQI dashboard is a tool to identify variations in the care delivery among providers and also to pinpoint value improvement opportunities. Based on the CQI index for the patients, we can also calculate the CQI index for the clinicians. And here you can see that the CQI index on the left shows the clinicians and the variation in terms of the outcome of the CQI. This slide shows the CQI trend for complete dentures. You can see that COVID, affected because of the lockdown in Singapore, affected the CQI score. The mean score is hovering usually about 30 to 40. When we break down the CQI by individual indicator, we notice that indicators like the wait time to treatment and also the wait time to completions are the one that's actually lower. And we have since then make improvements by having appointments that are linked together so that patient, once they start treatment, could have completed it within a short duration. Collection of prompts and prams. In this instance, we administer the prompt at the start of the treatment, then we do it again at the end of the treatment. So this is done through a QR code and also by manual distribution of the survey forms. The prams, which is patient's experience, is then done at the end of the treatment. Why prompts and prams? It is a very powerful tool to support patient-centered care because it gives us the dimension of patient's perspective about their experience, about their interaction with the environment, and also about the care they received. The prompts and prams trends for all dentures, you can see that the end prompts are significantly higher than the start prompts. In terms of the prams, we have been managed to be able to consistently maintain it at a higher level. Those areas which are zero are those when there were no forms collected. We also like to share from a larger perspective the collection of prams. This is a collection of prams not for dentures, but for the center center-wide that was done. And it actually talks about whether patient would definitely recommending the care to other people. And you can see that when we did the survey using the manual method, the average score was 81%, and it has been consistently 81%. Somehow or other, in May 2020, when we introduced an online survey, right, and scores actually went down by 3%. And we put two together, the score was 78%, and this is reflective of the new scores that we're going to have. So what I'm trying to say is that when you do prompts and prams, we just need to be mindful that the survey methodology would impact on the scores. We leverage on our partnership program to set cases out to our primary care partners. So for dentures, we have cited, since we started in 2019, we have cited 228 cases. There are simple cases that can have been managed by our primary care partners. And in terms of patients that have been cited out, we also look at their satisfaction score, which is at 95%. Now I'll present on the integrating oral health to general health. In terms of maternal and child health, we have an infant oral health program. We introduced this program because the prevalence of childhood caries actually is quite high, especially at preschoolers. These are more prevalent in those with lower socioeconomic status. And those children that had dental visits were 3 times, without dental visits, were 3 times more likely to have severe early childhood caries. So under this program, it is based on a risk-based preventive program. We have oral health education. We also provide anticipatory guidance on diet to the parent. And also we provide clinical examination and fluoride therapy. Since we started this infant oral health program in December 2020, we have more than 81 patients that have been enrolled in the program. So this upstream program, we are thinking of actually scaling it, and we are looking at having an even oral health program at the community. So what we mean by at community is that we'll have collaborations with our medical colleagues, the doctors, the family medicine, the pediatrician, and also the therapist, oral health therapists and dentists at the polyclinic to help with the screening. At the same time, we're also moving one step further to actually look at pregnant mothers, to actually provide training and education to pregnant mothers in terms of oral health. This will be done in collaboration with the polyclinics and the Women's and Children's Hospital. The Project Silver Screen is an integrated oral health screening. We integrated together with the vision and also for hearing. It is done in seniors who are 60 years and above. So since we started in 2018, we have screened more than 24,000 seniors by the enrolled nurses. And out of 24,000 that have been screened, about 26% had abnormal dental results. And this is based on the OHET screening methodology. So the seniors were then screened by dentists, and we have conducted 83 screenings where 643 of the seniors required to have functional issues, required dentures. They were then referred to our care partners, and those that required tertiary care were then referred to the National Dental Center to have their dentures done. I would also like to share with you the results finding from the Silver Screen project. The dental caries prevalence was 39%. An average of 2.5 caries teeth per senior. The prevalence of moderate to severe periodontal disease was high at 55%. In terms of number of teeth present, an average of 14.7 teeth, and 57% of them had functional issues. What we also notice is that the highest rate of tooth loss occurs at the age between 60 and 65. In terms of the OHIP scores, we use the oral health impact profile, and we actually stratify them by the region and also the subdomains. So when you look at the graphs, the northeast region, the east and the southeast region have slightly different scores. What we noted is that those residents, seniors staying in the southeast region, had a higher score, meaning that they have poorer quality of life. And when we stratified further by the type of domains, we found that physical pain and physical disability scored higher. That's question 3 and 4 and 7 and 8. Another interesting finding is in terms of the awareness and utilization of dental services. And when we asked when was your last visit to the dentist, more than 2/3 of them never even visited a dentist. And this frequency actually increased with age. And we were asked, why did you not see a dentist? And 63.1% said that they didn't see a need to because they didn't have pain. And a lot of these patients also had high dental decay prevalence. And the other reason cited was that there was no government subsidies or it was expensive. And a lot of these patients also had functional issues. Having 20 teeth is essential for good function. And this is based on the studies by Kaiser, Fukui, Khan in 2014. We are very impressed with the Japan 80-20 campaign. Having 20 teeth at 80 years of age were associated with better diet, nutrition, better physique, lower risk of gum disease. 9% achieved the 80-20 goal in 1979, and within about 30 years, it went up to 51.2%. The survey done in 2017 showed that only 9% of Singaporeans achieved the 80-20 goal. So we embarked on this inspired by the 80-20 campaign to go on the oral health movement 80-20. So the oral health movement 80-20 aims to encourage Singaporeans to retain at least 20 teeth beyond the age of 80. It's a phased approach. So we'll do oral health screening. At the same time, we will also do validation of the questionnaire that we're going to use for screening. And the next phase, at phase 2, we'll be doing oral frailty intervention. And subsequent to that, we'll review the results and hopefully we'll scale it at a national level. So the concept of oral frailty is defined as a decline in oral function. It affects one's ability to chew, swallow, speak. And the right side shows the questionnaire that we used during the examination. To do that, we have to forge partnerships with our community partners, and these are actually the community nurses. And we have trained them, and basically through upskilling the community nurses to help us with the screening. And they are a group of very enthusiastic nurses whom we have been able to collaborate to do the screening in the community. So this slide shows the journey that we'll be embarking on. So now we're actually in the middle at the oral frailty screening interventional program. This program is delayed because of COVID and because of the lockdown that happened. This is the results of the screening that we have tasked so far before the COVID. So 97 seniors that we screened, and out of that, 24 were actually pre-frail and 8 were frail. These are screening done at community dwelling seniors. The other part of the studies is also to look into the association between oral frailty and physical frailty. So this part of the studies, actually we tap along the SG70 studies that look at seniors, those who are age 70, sorry, right? So the intent of this study is actually to look at whether there's any causal association between oral frailty and frailty, and also whether there's agreement between the clinical oral presentation and the oral frailty scores. The other program that we have started is the oral health education program. This is a train-the-trainer model to educate non-dental healthcare professionals in oral care. So far, we have trained more than 114 nurses, and they would then train their juniors in terms of ability to basically assess the oral condition and to refer them if they see any abnormalities. And the training consists of the voice annotated online learning workshop with a 3-month on-site evaluation and a 6-month competency assessment. And the program evaluation came back quite positive because in terms of program learning, individual learning, overall assessment, they're scoring very high in terms of a total score of 5. We also noticed that since we started over a period of observation from July 17 to August 19, after we have put in the intervention with the OHEC workshop, the chronic sick unirespiratory related infection rate has actually came down from the baseline median of 7.5 to 3.5. We are also leveraging on IT in terms of telehealth, to bring this care in the community. So the tele-dentistry supported oral care program for seniors basically involved remote assessment of seniors' oral condition using a intraoral scanner to determine the treatment needs and urgency of the treatment. So this project has started last year, but was also interrupted because of COVID. And we are hoping that once we are able to validate this method of screening, we would then bring on to the next phase where we would use the mobile dental bus to provide the treatment to the seniors that have been deemed to require dental treatment based on the screening. So this is an integrated care pathway leveraging on teledentistry for screening and monitoring of oral health using a mobile dental bus. This will provide a seamless model of care for the vulnerable and underserved seniors living in the intermediate long-term care facilities with mobility issues. We are also looking at smart RPD, whereby we are creating a pathway for printing dentures and reducing the number of visits required. So this is currently at a stage of proof of concept. We are also looking into developing software with an AI capability that will allow the AI to actually guide the designing of the denture, but of course the clinicians would have the ultimate control over the design that's required. And hopefully we can reduce the number of visits from 5 to 3. So this is exciting, and we are hoping to see results coming soon. This is a snapshot of the our population oral health initiative across life stages. So basically, I've described the infant oral health program, the oral fluoride screening, the oral health education, and also the Keynote. Last part of presentation, we're talking about the building partnerships with primary care. As you can see, because of aging population, there's a shift of the center of gravity to primary and community care. And our next generation of primary care, will be actively involved in providing care at the community. And we will support our primary care general dental practitioners in the community so that, they will be able to see the patients that need basic and intermediate care, while the specialist center will see patients that require tertiary care. So we would like to highlight to you, as far as our partnership has started since 2018, we have more than 81 Trust Dental GP clinics distributed island-wide. And these are our care partners for us to cite our patients to them. At the same time, to also provide shared care, whereby patients could see them for one visit and a subsequent visit for follow-up with us. These are pertaining to patients, periodontal patients that, that can be shared care with our care partners. These are basically some statistics in terms of our care partnership program. And since we started in 2017, we have cited more than 1,380 patients to their primary care partners. And over the years, we have recruited more than 44 care partners. And we have about 6 programs that's under these care pathways. And also, in terms of satisfaction, patient satisfaction with the survey, and that we asked in terms of the experience with our care partners. Most of them actually scored very high. It's within 80 to 100%. Moving forward, our next generation primary care is to have a national dental primary care network. This is a work in progress, whereby it will be anchored at a polyclinic. And GDPs under the Community Health Assist Scheme will form a network and collaborate with the polyclinics. All right. So there will also be collaboration with the specialty centers like us with the polyclinic. So we will be the source for them to refer their complex cases, and also for us to share best medical or clinical practice with them. So the benefits of dental PCN, a whole myriad of them. Basically, it allows appropriate care setting. It also provides convenience for the patient. It will provide price transparency, and also it will provide timely access to dental care. In 2019, we launched the National Dental Research Institute of Singapore, and we aspire to be a leading institute for oral health care or research globally, to renowned for translating research into practice to improve oral health and general health. So under our NDRS, there are 3 arms, and I would like to highlight to you the SOPI, which is a Singapore Oral Population Health Initiative. So basically, it aims to improve oral and general health of the population through research, education, and policy. Under the population oral health, the SOPI have basically 6 research teams. One is on surveillance system, looking at oral disease burden, unmet needs. Second is on the life course studies. We're looking at birth cohorts, aging cohorts, sort of life approach to oral disease prevention. Third one is on data linkage, to link oral health and general health and to see whether there's any causality. Fourth is on implementation science, looking at simulation and interventional studies. And fifth is on health economic, looking at prompts and cramps, and also value-based care. In conclusion, I would like to mention about the key element in developing, a population health strategy approach should be on a whole of life. We need to have a whole ecosystem to anchor care in the community. And also we need to have a beyond public institution to have a whole of a society approach. So we need to form partnership with our partners in the community, non-healthcare and healthcare in the social aspect. And at the end of it, whatever we intervene at the population community level, we need to have an outcome to show that whatever we have done, we see the results. Studies have also shown that a lot of these population health initiatives, it took about 17 years to be able to translate out to practice, right? So lastly, I'd like to mention that in terms of a strategy, there must be a bridge between research, practice, and policy. With that, I thank you.
Okay, thank you very much for a great presentation. Your presentation includes many hints for everybody's future direction and the future ideal situation of the dental community, and also some total community. Okay, thank you very much. Any question from the audience? There's so many questions. So far from me, maybe some sharing some outcomes or indicators of the individual's clinic. And so how can share the data or monitoring data? Or it's a government screen, or maybe shared by individual, and for example, one clinic can compare some outcome of others.
Okay, thanks, Ken. Okay, so basically, I just probably want to refer you to the value-based care that I showed, where the clinical quality index, we can actually get the data, right, by the clinician level, by the clinic level. So unfortunately, you see, this one is actually currently rolled out for the medicals. Like say, for example, total knee replacement. They have a standardized way of measuring the outcomes across all the hospitals. Then they can take that and compare between hospitals. Unfortunately, in Singapore, we only have one dental school. So to compare between dental institutions is going to be quite challenging. We are ahead of the curve, but we hope to spread the value-driven care in dentistry, because when you look at value-driven care across the world, there are not many adoption in terms of the dental fraternity. Actually, that's a very good way for us to improve of the care for our patient by looking at variations and all that. And if we can move them, then there's a commonality to compare, then I think the results will be good. I mean, the government is trying to push, but it's only we comparing amongst ourselves. So our current improvement is between clinicians rather than between institutions.
Okay.
Yeah.
And maybe, so of course, many clinicians think about some patient-based or patient value. And maybe some clinician is hesitate to join this some comparison or re-evaluated. So what is the motivation or incentives for the dentist, or maybe penalty or incentives?
Yeah, okay. So this is a very sensitive issue, right? So when we develop the indicators, we actually ask them, what do you want to measure? They have to own it. If they don't own it and you just put it on them, then they will say that your indicator is not measuring what I do. So our indicators will be on like wait times patient waited, the outcome of the denture treatment, patient reported outcomes, and whether there's any redo of the dentures. So the clinician must say that, okay, we are comfortable with this. And the other thing that we also have to look at is that to extract the data, the system must be able to pull the data. If not, there's a lot of back-end manual data collection. Yeah, so we are still in the process of refining that. But if the clinicians own it, and when you flash the data, they compare amongst themselves, then they would say that, wow, you do better than me. What did you do to your patient that I didn't know? And then they share best practices. That's what we are currently doing. But it is not a top-down approach. It's more of a top-down guiding, but a bottom-up approach.
Oh, great. Okay. Okay, some questions, but it's time to close this session. Thank you very much for maybe suggest many things for some healthcare transformation. Okay, thank you so much.
Okay.
And so we are closing this session from medical anthropology, big data, and healthcare health service transformation. Covered many variety of some research and activities in this session. But it was great session to show the future direction of research and activity. So I hope so maybe next time some collaboration with each countries and maybe so we were so aiming for the future goal of new normal society. Okay, thank you so much. So we are going to close this session today. Thank you.
Thank you very much.
Okay, thank you.
So this concludes the program for today's symposium. Tomorrow morning session will start from 10 a.m. Japan Standard Time, and webinar URL is same as today's one. So we look forward to your participation. Thank you for your attention.